Dr. Rav Singh, welcome to the conversation. How are you?
Good. How are you doing? Thanks for having me.
I'm good. I'm good. Thanks for having me at your beautiful, beautiful home. I appreciate it. It's the first guest I've had on that's had me stay at their place, so I appreciate it.
Oh, wow.
Yeah,
Yeah, anytime.
it's super nice. So no guest is above or below an introduction. On this podcast series, we have people from military, athletics, healthcare.
Hmm.
So it gives people kind of a gauge of who we're talking to. You were the first guest that I broke my rule for. I have brought a notebook.
Mm.
I have done all of these, and like I told you before, I do them without planned questions. It's more organic that way to have kind of a Joe Rogan style.
For sure.
Given the topics that we're diving into today, I wanted to be prepared on some statistics
Mm.
and a couple points that I really wanted to go over
Hmm.
and I don't want to forget. So this isn't a planned interview, but there are some topics and trends that I've documented. Also, because I really want to know a lot about each guest and take my time with it, I do the intros off the top of my head.
Mm.
There's no way that I can remember your intro off the top of my head.
Mm.
It would be impossible. So you and the general were the two guests where I had to write it down.
Mm.
So we'll start with the introduction and then we'll just flow in.
Sure. Sounds good.
Let's do it. Okay, so Dr. Rav Singh's from 1997 to 2006, you got your medical degree at Ottawa University, then general surgery training at McMaster. In 2011, you became chief of surgery at North Bay Regional Health Center while getting your physician executive MBA at the University of Tennessee.
Mm.
While being the chief of surgery, you got your master's in healthcare at Harvard University and became the NSQ IR Surgeon Champion. In 2023, you became a certified life and wellness coach, and you are currently the president of the Ontario Association of General Surgeons. In 2017, you won the Innovation Award for Visionary Problem Solving. Your focus is on GI surgery, improving the efficiency and community bridging in healthcare. Also, a lover of golden retrievers, golf, the Masters, and the doctor who in early 2022 told me to go to the ER when I was really sick,
Hmm.
which ended up saving my life. So, what an intro. What an accomplishment for what you've done. And I've always wanted to ask you something.
Hmm.
When you hear me say all of that, do you think you're smart?
I think there's a difference between being smart and intelligent. Um, Being smart can doesn't necessarily mean you're academically smart. You can be smart in life, meaning you know how to navigate life. And I think a lot of people don't have that, uh, especially academics, right? Um, I think smartness is an evolving thing throughout life. I don't think I could say to a certain degree I might be smart, but it's an ever evolving thing throughout life where your smartness changes, right? And it depends on your capacity as well mentally. And so at this point, I would say I'm smart, but there's always, you know, a chance of it evolving over time.
Got it. Great answer. Before we dive into the GI stuff, which is the first topic, I brought you a gift.
Oh, thank you.
So, this is a race bib of mine that I signed for you.
Oh, wow.
This is the race that I
Impressive.
did before I ended up having to go into the ICU for 2 weeks with pneumonia.
Wow.
So I thought it'd be fitting to give you that one.
That's amazing. Thank you very
So you can
much.
keep that. Doesn't matter. You can throw it out. You can keep it wherever. But I thought that it would be nice to leave you with something signed of mine.
It's amazing. Thank you.
No problem. So GI.
Hmm.
What would be three fundamental signs that someone's GI health isn't where it should be?
So the common things we or I encounter, are they getting bloated after eating?
Okay.
Okay. Are they having irregular stooling patterns? Um, or if they're kind of not maintaining weight or have excessive weight, that'll tell me there's some disruption in the equilibrium of their GI tract.
Got it. Is that because they're consuming more calories than they're burning? So there's a lot of food sitting in that in their GI tract?
No, not necessarily. So you can't really correlate calories and things sitting in the GI tract to being overweight. Um, you've probably read through your readings, more and more studies are being done of the gut microbiome, right?
Yeah.
And how it affects our overall health. And I think more and more research is going into that in terms of how do you actually nourish that. And there's strong correlations like eating whole foods, fiber, things like lentil, legumes, nuts, uh, good fats like oils, avocado. All these things kind of nourish your own microbiome, and everybody's microbiome is genetically determined, as they say in research. Um, and things that injure it, anything that's kind of artificial in our society, right? Artificial dyes in foods, in pro-inflammatory foods. Um, so these things, by having a strong gut microbiome, will generally predict how your health is overall. Calories in, calories out. It's an interesting question because you could still be eating healthy, but still over consuming on calories. I remember my music teacher, he went no carb, trying to lose weight, but he's eating 3 to 4 salmon fillets a day,
Mm.
right? And he didn't realize each salmon fillet was like 300 to 400 calories probably. So even though he was eating healthy, he was consuming too many calories to the amount he was putting out basically. So to your statement, yes, it's partly true. Calories in, calories out can determine um, you gaining weight and being overweight.
Yeah, got it.
But it's not about weight in reality, it's about your body composition, right? Some muscular people are considered obese because of their BMI, but they're all muscular, right? So I think body composition is more appropriate as an indicator, as well as chest to waist ratio as an indicator of health, basically. I'm considered overweight. My BMI is 28,
Right.
right? But it's those ratios and body composition that really predict what your health is like.
When I coached powerlifters for many years, almost all of the men that I coached were quote unquote obese because of BMI,
Mm-hmm.
many of whom had abs and were very jacked and very healthy.
Right.
Why does BMI continued to be referenced and used by doctors knowing that?
It's an easy measurement, height and weight, right?
Mm-hmm.
So it's an easy thing to calculate. It's not perfect, um, but it's an easy calculate because it gives you maybe an idea, right? But I think excuse me, going to depth of calculating chest to waist ratio, calculating body fat percentage, that's time and it's laborious to do, right? So in an office setting, what's an easy way? There's calculators online, you can calculate a BMI like this, right? But to do all those other things, measuring the patient's chest, waist, um, having a caliper to assess body fat percentage, that takes time out of a doctor's time, office time, right?
So efficiency.
I think so, and I think that's why they just lean on BMI because it's fast to calculate.
And I guess BMI technically is accurate for a certain subset of the population for sure.
Yep, I agree.
But obviously, as we mentioned, there are a subset that were just widely inaccurate.
Mm-hmm.
And then you kind of alluded to it a little bit, but what are three, two, doesn't matter, really low hanging fruits that anyone can do to see significant improvement in their gut health?
Eat real food and basically move, walk, exercise if you can. Um, those are just basics. that can drastically improve your health in a short period of time, basically.
Do you consider walking as a form of exercise?
I totally do. And I think if you challenge yourself with the walking, a little bit up hills, upstairs, uh, downstairs, because that'll put tension on quads, right? So you're stimulating muscles in different ways. Uh, Walking on a flat surface for a long period of time, yes, is beneficial, but it may not take you to the next level of stimulating your body to be healthy, right? Um, some fitness trainers will say all you need to do at the gym is put your treadmill incline 10, 15 degrees and walk at 3 miles per hour for 30 minutes, and that'll be better than running, right? In terms of the gains you can get from it. So I think walking is a very powerful, and I think changing it up from flat surface to taking some stairs, changing elevation, I think that can take you to the next level with respect to the walking as well.
Yeah. I want to ask you that question because me being so involved in the fitness world, I have, I wouldn't say issues, but grave concerns for people in the fitness space that make statements around walking not being exercise.
Mm-hmm.
And if you are a competitive marathoner,
Mm-hmm.
maybe walking isn't a lot of exercise for you.
Mm-hmm.
But people, as you know very well, and I've experienced in my family, coming out of surgery or are overweight, there are people, if they go for a walk, where their heart rate will be 110, 120, 130,
Mm-hmm.
and they're getting some aerobic benefit, they're moving their body, and it's significantly better than not moving at all. So I think that I agree with you that walking is a great exercise. And it's interesting because you mentioned the running and the incline. Me being someone who ran a lot, who also developed some significant surgeries and injuries from it,
Mm-hmm.
I think running is good. But if you are someone who's not interested in competing in running, doing the incline on the treadmill, I think, is a much better option for you for your health long term.
Or stationary bike and changing resistance, right?
Yeah.
For those like who don't consider walking exercise, again, you have to define what exercise is to you. Is it reaching a certain heart rate? Is it changing your VO2 max? Um, so, what's your definition of exercise, right?
Hmm.
If we reframe it, walking is a great movement, right? It's easy, you don't need equipment, and studies have shown great benefit from it. Even more studies, after you get a meal, you go for a walk within 10, 20 minutes, it decreases the insulin spikes, right?
Yeah.
So it has benefits. If you don't want to call it exercise, call it a movement. Because if you look around the blue zones around the world, what was common among them? They moved, right? Can it be defined as exercise? Again, it depends how you define. Like, what are the parameters that you define? What is exercise? It's like people argue, is golf a sport, right? How are you defining a sport, right? So I think it's just semantics. The positive thing is the person is moving, right? And I think that's the key because it's still stimulating muscle somehow, right?
When I came out of surgery, the bilateral popliteal, I always say that wrong, which I should say right, entrapment and
Mm-hmm.
tibial neurolysis, I clearly couldn't walk for a week or so.
Mm.
And when I hired a really, really good coach, he had me doing 20 ankle pumps on the hour
Mm-hmm.
instead of timer. So for me, in that condition or state, laying down and lifting my feet up and doing this with my ankles is exercise because of the state that I was in. And then when I started to progress in movements, I'm someone who used to deadlift 500 pounds,
Mm-hmm.
and now I'm deadlifting or picking up 5 pound dumbbell off the ground. But for, like you said, if you're defining it from where, for exercise, from where I am, that 5 pounds is significant versus coming
For
out of the
sure.
hospital bed.
For sure.
So I think walking is a great modality for everyone. Have you seen that recent research on, they did brain scans before and after, I think it was a 20-minute walk, and like their frontal lobe, cognitive function, mood, serotonin
Mm-hmm.
was all improved from a 20-minute walk.
100%. I think it stimulates hormone release, endorphins, right?
Right.
Even if you don't consider it an exercise, it's still a positive thing.
Yeah.
Right? It's still beneficial for you. How you define it, becomes irrelevant at some point because it still has benefits. So if the goal of walking, if the act of walking creates benefits for your health and mentally, physically, then I think it's a positive thing for somebody.
Sorry, go on.
And going back to exercise, like even in music, your teacher will tell you do these exercises, right? So it's a term that's broad, can be used across any kind of modality, right? So it's how you define what exercise means to you, right? Because it can be used in many ways.
I never thought about it that way. So eating real foods and getting some form of exercise every day would be the two low-hanging fruits that help GI issues.
Yeah, even if you can't exercise, move, right? There's some studies that have come out, if you do air squats periodically throughout the day, if you have a sitting job, it's beneficial for you, right?
Right.
You're moving. Is that exercising? Again, it's how you define it, right?
I think for me, how I would define it is, what's the alternative if you don't do that movement, right? Because if you're sitting down for 8 hours in a cubicle and you don't do any air squats versus doing, I don't know, 10 per hour, that's 80 air squats in a day.
Right.
Your body's clearly going to be in a better space for health and longevity doing those 80 than nothing at all as well.
Agree. I mean, if you reflect on Tai Chi, that's a movement, right? Very slow, intentional movements in Tai Chi, and it has benefits.
Right.
Right. So I think movement is the basic thing, right? And that could sort of transform into an exercise depending on how you define that.
It's interesting that you haven't mentioned supplements yet for gut health.
I think if you eat a well balanced, real food, whole food diet, quote unquote, as a lifestyle, then you're gonna meet a lot of those minerals and vitamins. Most people across the board are deficient in vitamin D, so I think that's a supplement people should take for sure, especially during the winter. Magnesium, most people are deficient in. Omegas, especially omega-3, people don't get enough of. And the key thing with vitamin D that a lot of people don't teach you, you should take with magnesium and vitamin K2, right? Otherwise, it doesn't get absorbed into the muscle or the bones. And it just stays within your circulation, causes calcifications. So those are probably the main supplements I would recommend that most people are deficient in, basically.
So try to find vitamin D that also has vitamin K, because you
can do a combo or you can take it separately.
Right. Yeah, because I always see the vitamin D supplements at like Shoppers.
Mm-hmm.
Some of them are vitamin D and some of them are vitamin D plus K. So you would advise, if you have an option between the two, getting the one with vitamin K as well.
Correct, or buy it separately and take them together. Yeah.
Got it. Yeah, especially being in Canada when we have limited sun in the wintertime or for a large portion of our year. I feel like seasonal depression that happens can be a byproduct of just not enough sun and vitamin D. Would you agree?
It could be part of the reason for sure, because vitamin D is a hormone, right? And it can affect many functions in the body. So seasonal affective disorder, I'm not an expert in that, but certainly could be because of the result of that as well.
Yeah, makes sense.
It doesn't affect everybody though, right? So there must be some other factors that play into a role there.
Is fiber good or bad for you?
Studies have shown fiber is good for you. Yeah. There's soluble, insoluble, and I think, again, it feeds your microbiome, right? Your gut bacteria, the good gut bacteria, and I think it helps with overall health.
In your clinical experience, because you've been a doctor now for almost 20 years, 20 years as of this year.
Yeah. Surgeon has for 20 years. Yeah.
Surgeon for 20 years, got it.
Yeah.
Do you think that majority of people are getting too little of fiber in their diets?
Yes, for sure. I mean, you see it in practice. There's a entity called diverticular disease, okay, that we see in our general surgery or GI practice, and uh, usually it's a result of not eating enough fiber because it's rare in countries where they eat a lot of high fiber diets. And we're seeing a trend. We're seeing this in the younger and younger people, right?
Mm.
You usually see it in 60-year-olds, 70-year-olds, but now we're seeing it in people in their 30s, and it's all a result of probably not eating enough fiber. There are congenital forms of diverticular disease, but the one I'm talking about is something that's usually acquired because you're not eating enough fiber, basically. So
Yeah,
it's a trend you see. Okay, what's going on? Because now we're seeing people with inflammation of the bowel secondary to this, and in their 30s, sometimes in their 20s.
wow. Yeah, I wanted to ask you that question because I always see conflicting opinions online, and I feel like the camp of individuals that demonize fiber are maybe doing a little bit of clickbait or rage bait propaganda. Are you a proponent then for everyone to obviously eat vegetables because those also get demonized in social media? But I don't understand why, because to me, eating some broccoli or vegetables sounds like a good idea.
So if we reflect on eating styles, people always quote Mediterranean diet is probably the best kind of eating habit, right? And so there's lots of fruits and veggies in that, right? Good balance of fats with the oils and nuts, and then you have your protein, right? I recently came across uh, an opinion where I think somebody from Japan criticized how we eat vegetables. And I think we tend to eat vegetables raw, but in their culture, they steam them for a bit, right? They don't cook them to the point where they're soggy, but they don't eat them raw either. And I think steaming them for a bit has some kind of impact for us to utilize it better, digest it better. Yeah.
Got it.
So I think eating raw uh, vegetables may impact people's GI system for sure. It may cause cramping or bloating, because there are enzymes. There's an enzyme for vegetables like cauliflower, broccoli, Brussels sprouts that creates that gassiness, right?
Yeah.
But by steaming them, it may make it easier for the GI system to handle. Right? So I can see where people would say vegetables are bad, but maybe we're not preparing them in a way that are suitable for our body.
Right. There's a word or term that you used a lot from dinner last night to today,
Mm-hmm.
and it's real food. How do you define real food?
Good question. Um, in this day and age, it's hard to know what's real, right? Because the industrial revolution with farming, and that includes vegetables as well, right? With pesticide use, etc., etc. What is actually real, right? How we talked about tofu last night, and is it bad for you? Does it increase phytoestrogens? And I think it's the processing of the tofu that's different than it was 2,000, 3,000 years ago, because these cultures have been eating it for 3,000 years, right? Um, so I think it's the whole processing things. But in general, for me, what real food is an apple's an apple, right? A celery's a celery. A steak is a steak. And that's what I mean about real food. An avocado is an avocado. There's no other ingredients in it, right? Uh, Somebody advised that if there's more than 3 to 5 ingredients in something, then it's being processed or being ultra processed, right?
Mm-hmm.
So real food for me is it the whole pure thing, right? But again, in the Industrial Revolution, farming, you know, corporations' profits, like you have to turn over product fast, and you have to do things to keep the crop to survive, right? So using pesticides and things like that, does it still make it real, like a real apple, right? But in general, I would consider things that are one ingredient real, right?
Yeah, it's interesting. I've changed my mind on the term real food or clean eating in
Mm-hmm.
the last 5 years. And there is a camp of people that fight back on it, but I think they take it out of context
Mm.
because technically an Oreo is calories. It is technically food. You can digest it, but we're talking about foods have that aren't as highly processed, foods that are highly nutritious, that give you lots of benefit, and not consuming foods that most certainly have a negative impact. And just because your body can process and digest an Oreo cookie doesn't mean that it's something that you should put in your body on a regular basis.
So you have to ask yourself, why are you eating food?
Yeah.
Like, what's the purpose of eating? It's to sustain bodily functions, right? There's certain things the body needs to function: protein, basics, protein, carbs, fats, right? But then you have your vitamins and minerals. Sure, you can take everything in a pill form, your calories, your vitamins, your minerals. I'm sure you can achieve that. But the goal of eating is to sustain your body, right? And you want to sustain it by eating things that have inherent nutritional value that supply those things for you, right? So your example of an Oreo cookie, yeah, it tastes great, right? But what nutritional value does it have to actually help your bodily functions? So really, that's the basic question I would ask, like in terms of it being real, right? So the question is, why do we eat, right?
Mm-hmm.
Is to provide sustenance so the body can function, right? Now, can you fast and the body can still function? Certainly, right? But that's the body's resilience in terms of using the energy it has, right? Until it's depleted to the point where you need to eat, right?
And correct me if I'm wrong, but you did a 72-hour fast last week.
Last weekend I did a 72-hour fast. I had my last meal on Friday 12 p.m. and my next meal Monday 12 p.m. And in between I had tea, coffee without milk, cream, sugar, lots of water with electrolytes, some things that would curb my hunger: apple cider vinegar, 0 calories, no sugar, right? But it's something that kind of suppressed my appetite a bit more. But certainly the fasting suppresses your appetite after a certain period of time. Um, I would
Is it like a
use.
bell curve?
Is there a bell curve?
Like you get hungry, 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 and then it kind of like settles.
Yeah, exactly. You'll
Hmm.
you'll hear your or feel your stomach growling, and um, but after that sort of point, you feel actually energetic. And I remember on the Saturday, I actually did 50 push-ups in a row,
Oh wow.
fasting. And I was like this is impressive,
Hmm.
right? And I actually had a bit of uh, pain on the dorsum of my foot, whether it was a bit of fasciitis or um, a tendon thing, and that went away.
It's interesting this word of inflammation
Mm.
and how it's used in social media. And certain things can cause acute inflammation, but that doesn't mean it's going to be systemic inflammation.
Mm-hmm.
But I still think that if certain things do cause acute inflammation, like significant, but not systemic, if you can avoid it, just why wouldn't you? And I think some doctors or scientists out there use that example of, yeah, you get a big spike, but it comes back to normal and it's not like a long term process.
Mm-hmm.
But if you can avoid foods that cause that, then why wouldn't you? And also, if you're spiking and then spiking and then spiking over the long haul, I
Mm-hmm.
just don't see how why anyone would recommend that.
Yeah, and I think systemic inflammation, more and more studies show that predisposes you to getting illnesses, right?
Mm-hmm.
Um, and again, there's certain categories of things you eat or drink that are pro-inflammatory, anti-inflammatory, neutral, right? And it's interesting. Everybody's everybody's different. How they respond to food or whatever they drink, people react differently. Sure, there's basics of body physiology and there's reactions in your body that happen if you ingest certain things. But requirements for you are different than for me. We could do the same workout, but your body requirements are still different than mine, right? Age, gender, uh, weight, what your goal is with respect to working out or your life, right? So your requirements of protein, carbs, fats is going to be different, even if we do the same workout, right? Ethnicity probably plays a role, right? Um, so whatever you kind of uh, fuel your body with, yeah, it can be, like I said, broken down to what's pro-inflammatory, anti-inflammatory, or neutral. Right?
While we're on this topic, I've also never done this before, but I have a question to ask you
Mm-hmm.
from someone else. Is that okay?
Yeah, for sure.
Got it. So we've talked about him a little bit on Instagram, but my friend Adam Jansen,
Mm-hmm.
he was diagnosed by a gastroenterologist. What? How do you say it? Gastroenterologist?
Enterologist.
Yeah, got that he had ulcer colitis,
Mm-hmm.
and he was put on prednisone, and they said it only goes up from there. So if the prednisone stops working, then they go to
Biologics. Yep.
biologics.
Mm-hmm.
So he was having issues where he was shitting blood 20 to 40 times a day.
Mm.
And he went to the GI surgeon. The GI surgeon said, okay, we'll get you on these medications. Adam said, is there anything I can do? Any like lifestyle habits or any changes
Mm-hmm.
that I can
Mm-hmm.
make? And he said, no, you got to take um, the medication. So he took prednisone, and a byproduct of that was his gut got a bit better, but his hips and knees started hurting.
Mm.
And then as you keep going, the medications get worse, side effects get worse, and he obviously can't perform at a world class level if he's
Mm-hmm.
doing that.
Mm-hmm.
So he decided to take matters in his own hands, and he only eats the same chicken soup every single day,
Mm.
and he had full remission of all of his symptoms.
Mm.
And he's on no medications. He wanted me to ask you, his words were very close to, how the hell can I go to a GI surgeon who I'm
Mm-hmm.
supposed to trust
Mm-hmm.
and they tell me that medications are the only option,
Mm-hmm.
when if he got you as a surgeon,
Mm-hmm.
the first thing you told me that you would have said to him was, what's your lifestyle and diet like?
Mm-hmm.
So why in our healthcare system can someone like him as an elite performer get such polarity or differences between doctors?
I think it depends on your experience and what you've seen in your career, right? Again, more and more research is being done on the dietary lifestyle things, the foods we ingest, what's inflammatory, anti-inflammatory. Ulcerative colitis is a autoimmune disease that causes inflammation of the colon, and it usually starts distally, so near the anus and rectum, usually the rectum, and then kind of can progress all the way throughout the colon. Um, in some cases, the colitis burns out on its own without any intervention, and that's been proven in literature as well. Some are severe where people need to get their colon out, where treatments have failed, traditional treatments have failed, right? And I think once you're in the system of healthcare, this is what they have in terms of their arsenal, right? Your medications. That's how we're trained. That's how we're taught to think. Unless you step outside of that and think at a bigger level, holistic level, you're not going to have that vision or that thought process. Okay, what's your dietary and lifestyle like? Is there anything in your eating habits that are promoting constant systemic inflammation? Uh, is there anything you're eating that might combat that, right? And it's hard to know nowadays because we talked about this, like foods are, even healthy foods are kind of contaminated with, let alone the processed foods where there's a lot of preservatives that we don't know how they affect our body. But we do see the side effects. More and more I see younger people with GI issues, likely side effects from um, these preservatives and processed foods that nobody studies, right? Um, for me in my practice, I always ask about dietary lifestyle, like because there are things you can probably eliminate and they may make you feel better, right? Uh, so a lot of pro-inflammatory foods, especially processed foods, junk foods, are going to create that systemic inflammation. So him kind of taking everything out and eating kind of bland, it can have an impact on the body, and I can see how that can affect and help heal him as well.
Because he's removing the foods from his diet that were causing inflammation.
Systemic inflammation, yeah, it depends on what he was eating or ingesting, right?
Mm-hmm.
Yeah.
Because he did that, he drank a lot of like Monster Energy drinks, and
Mm-hmm.
so he removed all of that. He drinks just coffee,
Mm-hmm.
demineralized water. He goes to a place in Ottawa and gets the collagen jugs filled with them, and then he uses that for all of his water. He has a whole bunch of water bottles, so if he goes somewhere, he fills them all up. So that was about 98% of it.
Mm-hmm.
He also saw some data. It wasn't big clinical trials of nicotine.
Hmm.
So he also does nicotine pouches
Okay.
for nicotine.
Yep.
He doesn't swear by it by any means. He said maybe it worked, maybe it didn't. But he tried it and felt like there was benefit to it. But I just find it very disheartening sometimes
Mm-hmm.
that we have medical professionals who are on such a wide spectrum where some just get the patient on medications
Mm-hmm. Mm-hmm.
and some, like you said, can zoom out and have that view. Why do you think you became a holistic? I describe you as to my friends as you are a holistic Western medicine doctor.
Um, See, surgery is interesting because you can do surgery and fix somebody, right? Somebody comes with appendicitis, you can take out the appendix, they feel better. So I don't have to deal with a lot of medication use, right? Other than maybe antibiotics, pain medications, maybe some antacids if dietary lifestyle things don't work. Um, I think it's from my own journey. So growing up, yeah, I was a bit of a chubby kid, fat kid, right? And I used to love to eat, like love to eat. And maybe about 10 years ago, 50, well, actually when I first came to North Bay, 2010, I became friends with a bodybuilder, right? And I learned so much from him in terms of nutrition that I never learned in medical school, right? And it was just fascinating to hear him talk about nutrition and the requirements and how to eat food, how much, when. And I think that just stimulated my processes in terms of how I would like actually talk to patients in terms of, okay, what's your eating habits like? Because when I trained with him, I actually, my peak weight for my height was 201 pounds. And that was during my surgical training where you're not sleeping long hours, you're eating junk, right? Pizza, fast food. So I went from 155 pounds in medical school to 201 at the end of my surgical training,
Wow.
right? And hopefully one day I want to do this study where you do baseline testing and all the new medical graduates before they enter residency training. Do your basic blood panel, BMI, all these stuff, and follow them along for several years and see how training changes you, right? Um, but nonetheless, I went 155 to 201, right? Significant, probably hormonal changes from not eating well, not sleeping, long hours, right? So when I met, his name is Dave, I got back to the 155, right? And all it was eating real food and exercising, like cutting out all the other stuff, right? So I think that put a different perspective in how I would actually, discuss things with my patients. I think the first line is okay. And actually, my doctor said when I was in that period of obesity, I would call it like metabolic syndrome, right? And that's sort of like, okay, that's not good, right? Especially being ethnic, South Asian origin, high risk of diabetes, heart disease. So that experience changed, and I still have frank discussions with him, and we talk about nutrition. And so I think it's important. I think that's why I kind of do deep dives in it with patients.
I find it very interesting that you said I learned more about nutrition from my bodybuilder friend than medical school.
Yeah. I think we had 1 or 2 classes on nutrition. Yeah.
Why do you think that is?
I think we're so concentrated on physiology, pathology, anatomy, right? And pharmacology, so how drugs work, right? Because we're in that era of pharmacology, helping you deal with abnormalities in your physiology, right? I think eating healthy, nutrition gets you to the point where you're healthy and may prevent you from getting chronic disease, right? And it takes effort, it takes consistency, discipline, effort to eat well and eat nutritious food, versus taking a pill for a symptom, right? Much easier to pop a pill. I think the value in nutrition, I think more and more people are studying it now, like the impact it has on the gut biome. And I don't think we academically knew that until the last couple of decades, right? Um, but historically, we knew most people eat real food, right? Um, and I think that's probably the reason. Yeah.
Yeah, that's fair. I always joke about it, but the gym bros got it right so many times over the last 30 years, where they, maybe even 40 years, but Arnold and those guys that were pushing exercise and sleep patterns and eating better, more whole foods.
Yeah.
And now the literature is kind of catching up, but it's interesting how you learned that from a gym bro versus medical school, which I think is an issue for sure.
But if you take it from their perspective, that's their passion, right?
Yeah.
Bodybuilding, fitness is their passion, but how do you optimize that? So through years, they learned you're fueling your body, and how do you fuel it, right? And I'm sure they experience, if you don't fuel it with these kind of foods, then it's going to hinder you. So it's probably through experience that they learn, okay, you got to eat like these types of meals, right? And it's a science, actually. If you actually deep dive and talk to these bodybuilders, and when they're prepping for shows, it's like such a science. Like what to eat. They're changing meals like after sending pictures in of your physique, if you're training under a bodybuilder. Once a week, send your weight, send your pictures, front profile, right? And based on that, they don't even see you in person. They can tell you what things you need to change. As long as you're true to what they're telling you to do, They can just look at your pictures and what your weight is and say, okay, we're going to change this, this, and this in your diet. Like that's science to me, right? So they've dialed it in that it's a science for them, right? And what works, what doesn't work. And what works is eating real food, quote unquote, right?
Yeah, I think that I best describe Western medicine as, I don't describe it as healthcare, I describe it as acute care, which you then added last night. I think you said sustained care
Hmm.
instead of acute care.
Mm-hmm.
And I'm not, I wouldn't say I'm anti Western medicine by any means. I think there's a lot of value to certain things. But I think that we placed way too much as a society as an emphasis that it's the sole area or responsibility. Hi, Hugo, you can join for the for people's health.
Yeah.
When if you need, you have a really bad infection or an acute trauma, car accident, yeah, of course, Western medicine's there and it's amazing for that. But in terms, I feel like for holistic lifestyle interventions, I don't think it's good at, I don't think it's helpful almost at all. Would you agree with that?
When hospitals are first, supposedly that's historically what they're meant for is acute care, right? They were built to deal with emergencies and urgent care. And I think that's shifted over the years where now we're dealing with people with chronic disease who have setbacks from those chronic diseases. Does that
Yeah.
does that make sense? So, for example, somebody has emphysema from years of smoking or occupational working in a field where occupational hazard created some lung disease. So now they have this chronic condition with their lung, but they're going to have setbacks. They're going to get superimposed pneumonia, or they're going to get um, acute respiratory distress because of the underlying issue, because something triggered them to have that, right? So we're dealing with acute on chronic conditions now, right?
Got it.
So they have underlying issues. And then we have chronic conditions that, again, that cause setbacks. So people with diabetes developing neuropathy in their feet and don't feel a wound and then it gets infected, right?
Mm.
So as a result of them having diabetes, poor circulation, develop infected ulcers and infected wounds on their feet. So they require sometimes hospital stay for IV antibiotics. Um, Exacerbation of, heart issues. So there is some component of acute, but there seems to be always an underlying chronic issue to these patients as well, right? In the surgical world, we do deal with patients who have chronic disease, but typically we'll deal with the acute surgical issue, right? So somebody may have diabetes, emphysema of their lungs, but have appendicitis. If they're stable and fit enough to undergo anesthetic, then we take out their appendix and they feel better and can go home, right? Um, so the shift has happened where you have more people in hospital, right? And it's multifactorial because they have these acute exacerbations of their chronic disease. Or two, there's a point where family members, friends, caregivers can't take care of them anymore, right? But there's limited spots in nursing homes, long-term care facilities to accept them. So you see these patients in hospitals as well. But yeah, so overall, hospitals are meant for acute care, but it's shifted towards having more and more chronic people with chronic illnesses with acute exacerbations of those in hospital.
Right, because if you remove the appendix, that individual feels better. However, they go home and they still have type 2 diabetes. And then having type 2 diabetes is going to lend in the future likely or potentially lead to a higher chance of going back to the hospital for another acute issue that comes up.
Correct.
Did I hear that right?
Correct.
Got
As
it.
long as you know people who have exacerbations of their chronic disease, for the most part, sometimes aren't compliant with their management or treatments, right? So diabetics who run their sugars really high and not compliant, checking their sugars on a daily basis, or taking their medications as recommended, run into these acute issues as well, right?
Mm-hmm.
And sometimes certain triggers like infections of any sort can trigger their diabetes to go, out of control as well, right? And that can make them feel unwell too. Um, yeah, so it's a complicated, complex uh, system within our hospitals at the moment, right? And you see it across the board, right?
Yeah, for sure. It's interesting because I told you a story last night, but I'll revisit it now that we're talking about diabetes. So when my father went to the hospital for other issues, they found out during that time that he's been a type 2 diabetic for quite some time.
Mm-hmm.
And when he left the hospital after he got the care that he needed and to restabilize, he was given a dietary protocol to follow.
Mm-hmm.
And the order of foods to eat, one of the top one was 6 to 8 servings of whole grains
Mm-hmm.
and carbohydrates every day.
Mm-hmm.
Now, my mom isn't in the medical field by any means, but she lives a very healthy, holistic lifestyle. And she heard about some cardiologists on a podcast talking about patients who have heart issues and also type 2 diabetic for the short term anyways, do a carnivore diet
Mm-hmm.
just because their blood sugars, we're not talking about being at 6 or a 7.
Mm-hmm.
They're at 13 and 14.
Mm-hmm.
So my father did follow the carnivore diet for a couple months, and he actually got off of metformin and wasn't on any medications.
Mm-hmm.
And he would check it every day, and he was within the physiological ranges that you want to see. When he went back to the diabetic dietitian, she asked him how he did what
Mm-hmm.
he did,
Mm-hmm.
and he shared it with her. And she said, "No, you got to go follow this DASH diet, which is the same diet they originally gave him when he left the hospital." And it's infuriating to someone like me because obviously that's my father and I love him.
Mm-hmm.
And someone who lives a holistic lifestyle, who isn't a medical professional, got him off of metformin and those medications. But then when he goes back to the medical professionals, they tell him, just don't do that diet. Go
Mm-hmm.
back to this other diet, which spikes his blood sugars really high.
Mm-hmm.
Like that to me, I can't say that without thinking that's a broken system.
Is it a broken system, or are the people in the system not aware of the relevant literature or new research coming out about, you know, insulin resistance, insulin spikes, those kind of things, right? Again, we go through training in a certain way, right? Schools teach you in a certain way. We have our own experience, and the experience can be still what you learned 30 years ago, right? I don't think I'm the same surgeon I was 20 years ago, because you always have to reevaluate what you're doing. Is it of value to the patient or not, right? Um, are these steps in surgery or preparation of a patient for surgery, do they add value for their recovery, or healing? So you always have to ask yourself, like, what you learned, is this still relevant today? So that nutritionist may have learned what was appropriate many years ago in their training, but haven't updated their knowledge or looked into deep dives of, okay, what has been happening with insulin resistant insulin spikes, right? Recently saw a post on Instagram. What's the number one food that causes an insulin spike more than candy? And it's oatmeal, right? Um, so yeah, I think everybody has to update themselves in terms of what's happening in the literature, and is it beneficial for your patient? You need to change your practice, right?
Mm-hmm.
I think that should be an ever evolving thing for most clinicians, whether you're a physician, nurse, dietitian, right? So him going on the carnivore diet probably had less insulin spikes, lost the weight because Carbohydrates probably puts you in ketosis, right? So you're going to burn fat. You're going to burn your glycogen stores in your muscles and liver, right? And it's probably going to create a state where you're not spiking your insulin, right? Um, Long term, doing that kind of eating habit, is it good for the body or not? Hard to say.
Yeah, for sure. I don't think it would be something any that you would want to do, or I would want him to do long term. But
Mm-hmm.
that's a good example of, a modality that has been used with people to very quickly get out of the need for medications to keep their blood sugars in check
Yeah,
for type 2 diabetics.
and even more studies on intermittent fasting, like the 72-hour fast. I did myself. Some people would swear by that it does help your diabetes and helping you lose fat, right?
I think what's interesting for me was I had, I wouldn't say significant by any means, but I've always had some GI distress.
Mm-hmm.
And with having training a lot and a job on my feet and a lot of demands, I just think overall I had a lot of stresses.
Mm-hmm.
And then when I was eating foods, it was working in the restaurant, so I was grabbing a quick bite to eat, weren't the best food choices. So it was very common for me to get like some bloating after
Mm-hmm.
meals. And what you referred to at the start of this conversation, that's a sign that something is probably off.
Mm-hmm.
And since going to the farm for rehab, one of the things that I've changed, I do eat a lot better food choices, but I have a very small breakfast in the morning, and I
Mm-hmm.
don't actually eat again until maybe 6 or 7 p.m.
Okay.
So we'll just say 10 a.m. to 7 p.m. I don't eat. And I maintain my body weight. I still eat the same amount of calories.
Mm-hmm.
I sit around 178 every morning, but my gut health has gotten a lot better. It's better than it's ever been in my adulthood right now.
Mm-hmm.
And the two things that I changed was a lot of the food sources. But even if I do have foods that maybe aren't the best, it's still better than it used to be. And in my head, I'm thinking that gap of time where I'm not consuming any food
Mm-hmm.
is probably a beneficial thing for my gut. Do you think that's
For
possible?
sure, I think it is. Yeah. I mean, intermittent fasting, again, you're going to have people for it or against it, right? And I think that's with anything in life, right? You're going to have pros and cons and people for and against it. In the end, what feels good for your body, that's going to be appropriate, right? So if you feel good fasting 16 hours a day or 8 hours a day, do it, right? I've gotten into a routine where I get up, have 500 mils of water or 750 cc's of water with a bit of electrolytes. And then 2 hours or 2.5 hours after waking, I'll have my black coffee. And my first meal's at noon. And I'll eat between 12 and 6 most days. Sometimes I'll switch it up and I'll eat between 7 and 3,
Hmm.
right? If I am wanting to change how my body looks, or if I know I'm not going to be going to the gym those evenings, why do I need those calories later in the evening or later in the day? So why not eat while I'm at work, 7 to 3 or 7 to 4 or 8 to 4, whatever, and then let the body fuel my needs the rest of the day,
Mm-hmm.
right? But you have to find that sort of optimal point that you feel good and your body feels good, right? And a lot of studies are coming out where the body's still detoxifying sort of in the morning. So it's better to delay eating as well and
Mm.
not have breakfast. But then you'll have, camps that you should eat breakfast, right? But I think in the end, whatever feels good for your body and helps you improve your health, then that's what you should do.
It's that really funny video of a gentleman who's really big in the wellness space. I forget his name now. But he was demonizing oatmeal or something.
Mm-hmm.
And then it cuts out Kipchoge, the greatest marathoner ever.
Mm-hmm.
And they asked him in this interview, what does he eat before he races? And he says oatmeal.
Oatmeal. Yeah.
And I'm not sitting here like you talked about oatmeal earlier. I think it's important. And the reason why, well, there's many reasons, but one of the main reasons why I wanted to speak to you today is because you have a very open
Mm-hmm.
approach. You don't sit here and say, I do the 72-hour fast, so everyone's got to do the 72-hour fast.
Mm-hmm.
Or I do the 7 to 3, everyone does. But that's what I see a lot on social media is someone with knowledge or an expertise or good results does X modality, and then they generalize it to the population
Right.
that this did this for me. So if you guys aren't doing this modality, you're doing it wrong.
Yeah.
When it's interesting because the best marathoner of in the history runs off oatmeal when he races. So it's not saying that everyone should also just run off oatmeal. Some people might do better on an empty stomach. Some might do better just. So
Yeah.
for me, whenever I raced, it wasn't healthy, but I would have 3 pieces of white Wonder Bread specifically,
Mm-hmm.
and no name strawberry jam.
Right.
And for whatever reason, that I found over trial and error over 13
Mm-hmm.
years, settled the best in my stomach and some simple carbs before doing a race.
Right.
And I don't eat that every day or most days. But for me to sit there and tell every single ultra athlete to do that because I did that is, I think, disingenuous.
Yeah. Everybody's different, right? I remember my music teacher saying, "You don't have to be different as a musician. I'm teaching you things. You don't have to be different because you're a different human being. Your music will be different automatically,
Mm,
right?" So that really hits hard. Like you are your own person. Going back to the oatmeal, sure, it spikes your insulin, but I think in elite athletes, people who have muscle, it has less effects because you have the muscle capacity to store that glucose, right? So I think it's detrimental people who have insulin resistance, right? Because you don't want them to keep spiking their insulin. So I think oatmeal in that scenario, I think that's what they're talking about, like avoid it. But I think athletes, people who have muscle, I think it's okay because they can handle the insulin spikes because they have the capacity to store that glucose in their muscles.
I'm not sure if you're familiar or looked into this at all, but one of the biggest things in sports science right now, for let's say the last 4 or 5 years for triathlon,
Mm-hmm.
is getting the amount of grams of sugar per hour
Mm-hmm.
higher
Mm-hmm.
and what we can digest.
Mm-hmm.
And so, for an example, when Lance Armstrong was in his prime, it was always that number was 80 grams.
Mm.
And if you can get 80 grams, then that's great. And now with the Norwegians, Christian Blumenfeld, Gustav Iden, they're doing crazy studies in controlled settings with the best scientists in the world, and they're really pushing the limits. So
Mm.
now pro triathlons or triathletes very commonly do 120, 130,
Mm.
140 grams
Mm-hmm.
of sugar per hour. But so when I would do my long indoor rides in my living room, it would be maybe a 3 or 4 hour ride, and I would have 80 grams of I think dextrose with some water, and drink it.
Mm-hmm.
But that high amount of sugar that I'm intaking is being utilized because I would burn 3,000 to 4,000 calories on
Yes.
that bike ride.
Yes.
So I think people, like you said, is people need to be mindful that when they see Michael Phelps eating 10 pancakes with maple syrup for breakfast, they got to remember he's in the pool for 6 hours.
Correct.
So,
That's the difference. So when I was training with a bodybuilder, he would recommend eating oats, right? Because you're in that process, you're working out, you're building muscle. So your body has the capacity to handle that insulin spike and that excess glucose circulating in your blood, right?
mhm.
So I think it's more detrimental to people who don't have that scenario, right? So him eating 10,000 calories a day, Michael Phelps, um, but he's just burning all of it. He has a capacity where that glucose doesn't circulate. He doesn't have the insulin resistance, right?
Because I feel like type 2 diabetes has skyrocketed
Mm-hmm.
in our society,
Mm-hmm.
and people are moving less and eating more. In 2017, Stanford did a study, and it was on 700,000 people, which is massive.
Mm-hmm.
And what they did is and it was 111 different countries, and they gave an app to individuals that tracked their steps. Now, obviously, there's many variations. You forget your phone in your room, you miss step counts, so it's not an exact science. But when they extrapolated all of the data, the average step count in Canada was 4,913
Okay.
for the candidates. And I'm thinking to myself, when I came out of surgery, well, to this day, actually, I'm on a specific step count to average.
Mm.
And right out of surgery was 2,000. And I had a hard time staying under 2,000 with crutches by just going around the house to
Mm-hmm.
go to the washroom. So the average being 4,900. So me now meticulously tracking my steps. If I do a very chill pace, 40-minute walk, I hit 5,000 steps.
Mm-hmm.
So that means that there are many people getting below 40 minutes of time in their day where they're standing or using their feet in a walking motion.
Mm-hmm.
And then we look at calorie consumption going up, foods are more highly palatable, processed.
Mm-hmm.
It just seems like it's been a recipe for disaster for metabolic health. Would you agree?
Yeah, certainly metabolic health is, our metabolic syndrome is increasing for sure, right? We see that in our practices, and people are certainly on more medications. BMI is higher if you want to use that as an indicator for, being overweight or obese. Yeah, I think it's a complex of things that have kind of come together, right? Food we eat, lack of moving, and sedentary lifestyles, right? But now you're seeing this budding extreme where longevity, right? How do you achieve longevity, quality of life, right? How do you mimic blue zones around the world where they're living until their 90s and hundreds, right? Um, so you have this trend also beginning, right? But I think that just goes back to the roots of how people probably used to live, right? Going back to the carbs, like there's even new ideas like creating resistant starch with your rice, pasta, potatoes. So you cook them, put them in the fridge, eat them after they've been cooled down, and that creates a resistant starch which does not spike your insulin as much, right? Or cooking your rice with coconut oil. Supposedly it decreases the insulin spike. So there are ways people are studying, yeah, you can still enjoy these carbs, um, but how do you minimize the insulin spikes? Because that's what's creating inflammation or partly creating the inflammation disease, right?
Yeah, and I think it's not saying never eat carbs or demonizing it, but match your level of activities, get better sources. And for all of your 20 years as a surgeon,
Mm-hmm.
I don't know how many patients you've seen. I'm guessing it's going to be a lot. How, what percentage of them, just say you out of every 100, how many of them have at least one comorbidity?
The trend certainly increased in terms of how many patients I see have at least one comorbidity, and it's high percentage.
You're talking 9 out of 10 right now, probably.
Yeah, eight to 9 out of 10 for sure.
Mm-hmm.
Yeah, and they're on at least one medication for sure.
It's impossible to know and predict, of course, but do you think that if your patients didn't have any comorbidities, there's a lot of your patients that you just sort of you would never see, that they wouldn't have got to that point to see you?
Good question. I think for some GI symptoms, I'd probably not see them, right? But for things like appendicitis, gallbladder issues, colon cancers, those probably still would exist.
Mm-hmm.
Yeah.
Interesting. So let's talk about healthcare
Mm-hmm.
system more specifically. This is, I know it's a very passionate topic for you,
Mm-hmm.
and we got into it a little bit last night. My perception of healthcare in Canada right now is that it's not very good.
Mm-hmm.
And 20 years ago, I had a much different experience in healthcare than I do now.
Mm-hmm.
And with me having the surgeries and seeing many different specialists to try to find diagnosis on my MyChart file,
Mm-hmm.
I looked at it and I think it's around 23 or 24 hospital visits in the last 2 years for getting MRIs, ultrasound, surgery,
Mm-hmm.
follow ups, and are going to emerge. And wait times are crazy
Mm-hmm.
in emerge, insane. Like in Ottawa, it was at least 12 hours when you go in there for a wait time. In the last 20 years, the time from going into emerge to getting a hospital bed went from 9 hours to 23 hours.
Mm-hmm.
Access to family doctors is hard and limited. As a society, we've gotten less healthy.
Mm-hmm.
We spend, which was a very interesting statistic, in 2025, it average rounding, it was we spent $4,500 per Canadian citizen on healthcare. 2025, it was almost no, it was more than double that. It was like 95, 9,600.
Hmm.
So we're spending more than double on each Canadian citizen. Yet our healthcare experiences and systems are getting worse to the point where 2 weeks ago, a gentleman in Edmonton
Mm-hmm.
died because he had to wait too long in the emergency room.
Mm-hmm.
I think there's a lot of issues. And I wanted to dive into this because you're in it, but also you got your master's in healthcare management
Mm-hmm.
at one of the top three universities in the planet.
Mm-hmm.
So this will take up a part of our conversation. But let's start with emerge. Why are wait times insane? It's a very vague question, but
Good question. I think, a few years ago, especially locally, we were recognized for having good wait times, right? Um, it's always fluctuating, but the trend you mentioned, based on statistics, it seems to be increasing on average globally across the nation. I think there's multiple factors for this. I mean, increasing population, more people are unwell with comorbidities, um, aging population. So you have this whole context of this pool of patients. Okay. And then you mentioned access to primary care, which is limited. So now, if you can't get into primary care, where are you going to get access to get healthcare? It's going to be emerge, right? And I think that kind of creates a melting pot where there's many more patients in emerge. Now the system has a triage who's more important or not, which they have criteria for that. May not be perfect, but there is criteria who to triage sooner or later. And I think that's what kind of creates these wait times. It's sort of a simple look at it, but I think is because of increasing population, aging population, and unhealthier population.
do you think that
And I'll add shortage of physicians and nurses adds to that. Some emergency departments have been shut down because there's no manpower, right?
mm,
Especially in smaller um, designated emergency departments.
I'll give you an example that on October 26th, 2024, I went to emerge. I texted you that night, so you can validate this. But my right foot was like purple and blue, and I could barely use it.
Mm-hmm.
So I went to the Ottawa emerge. from when I got there to when I left was about 14 hours.
Mm-hmm.
About 6 or 7 months ago, I went to Emerge in Napanee,
Mm-hmm.
small town, and I got in and out in 2 hours.
Mm.
So technically, I could have drove from Ottawa the 2 hours to Napanee, got in the treatment, drove back to Ottawa,
Mm-hmm.
and we'll just be nice and say um, around half the amount of time.
Right. And I think we're seeing that trend as well, where patients will go to smaller hospitals that have an emergency department because they know it won't be as busy and they can get seen quicker and maybe get investigations quicker and dealt with quicker. And yeah, waiting can get frustrating for sure. Um, but I think the system is to a point where it probably can't handle the patient load, right? So how do you fix it? It's complex, right? You have to sort of decide, is it triaging? Is it manpower where there's not enough emerge physicians, which happens? Is it nursing manpower, which happens? Where you can't flow in more patients because there's no nurses to look after that patient in that bed,
Mm-hmm.
right? Certainly in bigger centers, there's more volume in emergency departments versus smaller emerge. But smaller emergency departments won't have all the resources they may need to treat you. So you'd have to be transferred to another hospital. For example, we have a hospital 20 minutes down the highway. They have an emergency department, but they don't have surgeons. So if there's a surgical issue, they have to be transferred.
Right.
And whether we have a bed available for that patient or not is another complexity that's added to it, right?
Yeah. I think it's easy for people on the outside to blame healthcare.
Mm-hmm.
And I think it's easy for people in healthcare to point to the outside of healthcare and blame the patients. But I think that it's got to be a combination of all of the things.
Especially in a socialist system, because there's many players in the socialist system, right? How do you create where not everybody's in a silo? The patient's not in a silo. People delivering the healthcare are not in silos, right? The administrative ministry aspect of it aren't in silos. Like I think there should be sort of a continuum that overlooks everything, right? And there has to be accountability across the board in terms of actually ideally kind of transforming the system.
Yeah.
Otherwise, the wait times may continue to increase, right? Patients might not get care in a timely manner. From a physician perspective, we want to take care of patients. Nurses do as well. We want to do it in a timely manner, right? But there are certain things that may hinder that, right? Do we have enough resources? Do we have actually enough manpower to collectively take care of a patient, right? Um, so it's a complex thing to tackle for sure.
I won't say his name because I don't know if you'd want me to, and I didn't get approval. But someone that I know pretty closely is a surgeon
Mm.
in Ontario.
Mm-hmm.
And I texted him maybe a year ago, 2 years ago. Maybe it actually was October 26th when I was waiting forever. And I have a screenshot on my phone of him saying, of me asking, is the wait times ever going to get better?
Mm-hmm.
And he said, not in our lifetime.
Mm-hmm.
Do you agree?
The way it's trending, probably not. Yeah.
I appreciate your honesty.
Unless there's a drastic systemic change. And again, it's complex, the number of pieces I go into wait times, right? Especially through emerge. And especially if society continues to get unhealthy, right? And especially if there's still shortage of primary care, whether it be nurse practitioners, whether it be family doctors, right? Um, it's going to have an ongoing impact.
You said that 8 to 9 out of 10 patients that you see have one comorbidity. So, as I looked into this before our conversation,
Mm-hmm.
so since 2005 to now, people that go to the hospital that report or are reported to have at least one comorbidity is up, I think it's 13 or 14%.
Hmm.
So I also think there's finger pointing that needs to be done also as a society from the perspective of individual responsibility.
Yeah, like I said, there has to be accountability in a socialist system, right? If we're going to have a social universal healthcare, there's many players from all the way from the ministry to the patient and in between, right? And how do we keep each other accountable? The system. So you have to ask yourself, what is the system designed to do? For example, Phil Jackson, coach of the Chicago Bulls, he had a system, right, for his team. He knew the players, he knew the skill sets, he knew what resources he had to create a system that won them championships. Pat Riley did the same thing for the Lakers, right? So the system they created was to win, right? Healthcare system is designed to, heal, right? Get people healthy, prevent illnesses if we can. So yes, I think part of our healing or health is in our hands for sure. Initiatives we take, but it has to involve consistency, dedication, discipline, right? If you look at bodybuilders, how do they achieve what they achieve outside of if they use performance enhancing drugs? Is discipline, consistency, right? Any athlete, how do they get elite? Dedication, consistency, right?
Mm-hmm.
So how do you get healthy? It's being dedicated that you want to be healthy, remain healthy, and that's by like what we talked about, right? Fueling your body with appropriate things that are nutritious and moving, right? It's challenging because it takes a lot of effort, right? I think we're in a society where instant gratification is such a big thing, or we want people to repair, fix things. Um, but nobody's going to be a hero or superhero and fix things 100%. There has to be sort of a two-way street, right? My music teacher gives me lessons. If I don't practice, how am I going to get better, right? Just because he gives me a lesson, shows me techniques, doesn't mean I'll be a good musician, right? Or good at playing that instrument. Same thing, I think, with health is we can give you tools, we can recommend how to get better, but there needs to be that effort as well, right? The medications, we can give medications to sort of subside symptoms, but at the core is the baseline health, right?
Do you think the information that's given to patients then isn't what it needs to be right now?
The information is out there. It's been years. You can search anything and it's out there, right?
Mm-hmm.
Going back to the music example, sure, my teacher can show me things or teach me things, but I think the key is how to practice, right? How to practice to get better. So how do we empower patients to, get them healthy themselves partly, right? And it was a big learning for me. Like I'd tell a patient to go lose weight and I'd leave it at that, right? But what tools am I giving them or is the system giving them to actually lose weight, right?
What's the country you mentioned that has that resource system for people to access to lose weight?
No, Japan.
Mm.
Yeah.
What's going on there?
I think they have criteria for primary care doctors to measure waist circumference. And if it gets to a certain point, I think they're put into sort of a process where um, they have to sort of stay lean, right? Because they perhaps realize obesity has an impact on the system and healthcare system and cost and those kind of things.
And then you also said one recently or yesterday, maybe today, that getting a rebate at 65 if you had a certain amount of hospital visits or less comorbidities because you took care of your health. Because I feel like there isn't an incentivized system outside of, I guess, feeling better in your own health. But a lot of people, as we know, that's not going to be enough to incentivize them.
Mm-hmm.
And I don't know the answers, of course, but I just feel like the healthcare system is being clogged by 85% of people that don't take care of
Mm-hmm.
their health.
People have been thinking about this for years, right? Do we tax junk food, right? Do we incentivize people for staying healthy, and when they reach a certain age and you look at how many times they've accessed healthcare, give them a rebate because they haven't been a burden, quote unquote. I shouldn't say burden, but impactful on the system itself, right? Um, People have been thinking about this for years. But how do you actually transform the whole system, right? And actually, if you talk to patients, they want to be healthy, right? Getting unhealthy is a slow process. That's one day it's like, oh my God, I'm unhealthy.
Mm-hmm.
Um, like I can't walk, or I can't do the things I used to do. When I got to 201 pounds, I had difficulty bending over and tying my shoes, right? And I'm like, oh my God. But it's a slow process over 5 years of training that it came to that, right? Because of the factors I talked about. But I think as a society, we need to give those tools and not just say lose weight. Okay, what resources can I connect you with, right? There's obesity surgery, right? How do we actually, we're trying, there's many thoughts of how to get society healthier in this obesity epidemic or chronic disease epidemic, right?
I found out about this obesity surgery last night,
Mm-hmm.
and at first I thought you were making a joke. Can you explain what that is and what's going on there? Because I don't think a lot of people know that.
Yeah, I think there's different types of obesity surgery. But the quote unquote gold standard would be a gastric bypass, where you create a little gastric pouch just beyond the food pipe or the esophagus. So you staple off the stomach at that level, and then you reconnect the small intestine to that remnant or small gastric pouch. And one calorie just passed through. Okay, so there's less chances of absorbing a lot of those calories. Two, there's hormonal changes in terms of um, helping you lose weight and affecting your insulin resistance or insulin spikes. So that's sort of the general theory behind that kind of surgery.
So people are less hungry and not absorbing as many.
And people lose a lot of weight because of sometimes they'll get diarrhea. Most patients have diarrhea and lose um, a lot of nutrients, calories because of that. So they have to be on multivitamins, right?
Hmm.
People can lose a lot of weight for sure, but people do rebound. In the literature, 25%, maybe 30% will regain their weight. And there's a subset of patients who have chronic complications from it. So I haven't looked at the recent data in terms of how it's impacted society, but that's something to be interesting to look at after so many years of doing this surgery.
I feel like if you've had such poor habits to get that obese to have that surgery, that you're going to get the surgery and those ingrained habits are just going to continue. It's so hard to change, as we know, any habits.
Yeah, and I think there's a whole process before you're considered to have surgery, and that includes like the psychosocial investigations of what led to this, right?
But doesn't isn't that process just going to create more people going to hospitals and clogging up healthcare because they want to get the surgery?
Not everybody wants to get the surgery though.
Hmm.
Yeah, because no surgeries without complications, right? Uh, and there's known complications from this surgery, and then patients will know somebody who had a complication, and it kind of turns them off of having it.
So I guess then some of those people that think about going through that process, when they discover more of the situation and what the surgery entails, it'll motivate them to maybe get that result
Mm-hmm.
through lifestyle choices.
Mm-hmm.
Got it. Yeah, that was just so crazy to me when you told me that.
Mm-hmm.
And then we also have GLPs,
Yes.
Ozempic, that is being used aggressively in this world right now, I feel like,
Yeah, it seems
especially
like it.
especially in North America. What are your thoughts on GLPs?
Again, it's going to mimic what we already have the ability to do through certain foods, right? Um, but again, that takes dedication, consistency, which is hard, right?
Mm-hmm.
So taking a medication is much easier, discipline, right? It doesn't require pain, sweat, preparing food. It has shown results for sure, but it has side effects too, like any other medication. So you always have to find that balance of the benefits of something versus the risks and side effects of things, right? And are you willing to accept the side effects or complications from a treatment? And that's what it comes down to, right?
Yeah, I feel like if you were someone who was, I don't know what the medical term would be, but significantly obese, I'm talking 4, 5, 600 pounds, close to
Mm-hmm.
wheelchair obese,
Mm-hmm.
GLPs would be beneficial at that point because the side effects from GLPs won't be nearly as bad as the side effects from being that big. But I also think that people who are maybe 30, 40, 50 pounds overweight, like you once were, would be far better off not taking GLPs and just changing lifestyle habits.
Mm-hmm. I think I think inherently we want quick changes.
Right.
If you talk to bodybuilders, they didn't get that way in a year. It took maybe 10 years to look the way they do, right? Without any performance enhancing drugs. It takes years and years to get a physique of a bodybuilder, right? But I think our society is instant gratification, social media, Instagram, Reels, TikTok. I want to lose weight, I'll take Ozempic, right? And what's in the background, I don't know. I don't know what their primary care discusses with the patient. Do they try dietary lifestyle, etc., before they try GLP-1, right? Um, but yeah, I think we're a society where we want instant results, instant gratification.
If one of your family members came to you that was overweight, would you recommend they take GLPs?
Again, I think I would try dietary lifestyle.
Yeah.
Even if you're 400, 500 pounds, just take the first step, right? And keep that going because at some point that consistency will pay off.
Mm-hmm.
Again, it's hard because it takes dedication, it takes a focused mind, discipline to do that.
I think one of the big frustrations with healthcare is individuals that do take really good care of their health that have or are more anomalies in the healthcare system. So, I mean, I'm an example, but who was very fit and healthy on every
Mm-hmm.
metric. And I got this issue, cardiovascular issue in my leg, which is really rare. But now I'm having to wait excessive amounts of times to get a diagnosis
Mm-hmm.
because I'm behind people who made really bad lifestyle choices
Mm-hmm.
and are in the hospital all the time.
Mm-hmm.
So I feel like those individuals, myself, can be frustrated. And I don't know there's an answer for that system, but I just find it the opposite of incentivizing because the people that do take care of their health are the ones that are actually being indirectly penalized the most.
Yeah, I think it comes down to not predicting the need, right? The system has underestimated the need, right, in terms of MRIs, CT scans, or any other testing, and the capacity for that. And I think that's what's causing the discordance, right, in terms of the wait times and the queues, basically. Um, Simple would be to increase MRI, CT scans, right, technicians, but that costs money and space. Like, how can you fit multiple MRIs in one place or multiple CTs in one place, right?
Because people, including myself, think that hospitals are this money making machine, but
Mm-hmm.
I've actually learned last night, and I looked into it this morning, that we are negative $100 billion in 2025 in Canada. We
Mm-hmm.
spent 400 billion,
Across the board.
but only 300 billion came in through tax revenue.
Mm-hmm.
So hospitals aren't even, our hospitals are in general are losing money. And all of my friends who have the means fly to America for healthcare
Mm-hmm.
because they get better healthcare. They get it really good surgeons and
Mm-hmm.
doctors. They don't have wait times.
Mm-hmm.
They get it if they get a negative, like for my case, I got a negative on the MRI with contrast,
Mm-hmm.
but a positive on the angiogram.
Mm-hmm.
But that whole duration from ultrasound to MRI with contrast to angiogram took 9 months. And then they found out that both my arteries are
Mm-hmm.
nearly obstructed. And oh shit, dude, you need surgery in the next 14 days.
Mm-hmm.
So when I was waiting to do my MRI, me and my girlfriend at the time called around at the States, and every single one of them said they don't do the specific one with contrast.
Mm-hmm.
But then I asked them, okay, just I'm curious, if I wanted to go down there tomorrow for an MRI, could I do it? And every single one said yes.
Mm-hmm.
I think it was $1,000. And I can acknowledge not everyone has $1,000 to spend,
Right.
but I find it alarming that the people who do have the money all go to a different country to get better healthcare.
Well, there's better because there's no wait time, right? I think the care, I think the care is equivalent, but it's just the access to it that's
Mm.
different, right? It's not like my training is inferior to the training of general surgeons in the States. It's just the access is different because most entities down there are for profit. And not all hospitals in the States survive either. A lot of the hospitals are either taken over or shut down because they're in debt, right? So I think it's more the access, easy access, but you have to pay for it, right? Um, and I think that's why they consider better healthcare or a better system. I wouldn't say better healthcare. It may be considered a better system because there's no wait times,
Mm-hmm.
right? It is a financial cost for sure, but the care itself is probably not different. The resources may be different in terms of the abilities of a certain MRI to do certain testing or certain specialized CT scans may be different as well, right? Um, but I think the care that can be provided is probably similar. It's just the access to it.
Yeah, you're going to get a really great vascular surgeon in Ottawa doing high volume as someone at Harvard high volume.
Correct.
Yeah. So,
So it's really, I think people are frustrated with the access. In a universal socialist system, we were, we think that we should have access like easily, right?
well, it's interesting because the people that pay the most for healthcare get, well, they typically need healthcare less, but they get worse healthcare access and treatment than those that don't pay anything for healthcare. For example, someone like yourself,
Mm-hmm.
you're a surgeon. If
Mm-hmm.
I looked it up on Google, it'll probably say, with your experience, AI would say, just say 500 grand a year.
Mm-hmm.
The amount of money that you pay to healthcare through your taxes
Mm-hmm.
is substantially more than someone who makes the median salary in Canada, which I think is 68,000. We'll just say 70,000. So it's just weird to me that you pay so much more money over your lifetime, yet you are triaged in the same system as people that contribute significantly less.
Right.
And there are people through bad, poor lifestyle choices and decisions and laziness
Mm-hmm.
that just say we're born into good families that decided to be lazy in life and they live off the government, so they don't actually pay any taxes towards healthcare, and they're getting the same as you, but you're paying way more. Like it
Right.
seems like it's not a fair. I know I'm poking you here, but I just seem like I'm trying to make this sense because in the states, if you've taken the necessary steps to become a surgeon, a lawyer, um, be an entrepreneur for your own business,
Hmm.
you make enough money to have the means for healthcare. You get it. But then in the States, if you're someone who is low social economic stature, you can go bankrupt for the rest of your life to get healthcare.
Yeah. Which is not fair to them either.
Right. So my position on it is that for healthcare and being through the system a lot is that I don't think anyone should ever have to go bankrupt for basic healthcare.
For sure.
I think when that happens in the States, it's not great
Hmm.
or it isn't great. But I also think there's got to be some better situation or solution. Because I know you mentioned India does private and public,
Hmm.
and I didn't know that a country did that. But I feel like that might be a better option than this socialist healthcare system that we have, because clearly what we're doing is not working.
So to your point where, yeah, high income earners are probably contributing more, paying more tax, contributing to healthcare costs more versus somebody who doesn't have a higher income. And I think it comes down to higher income earners have been shown like you have access to pay for a gym membership. In society, healthier foods is more costly, right?
Mm.
You may have access to personal trainers or have access to pay for yoga studios, etc., etc. Whereas low socioeconomic status, people in society wouldn't have that and subsequently have more health issues, right? Our indigenous population has like poorer health on average compared to the average Canadian as well, right? Um, so I think that's what creates that statistic, basically, right? If we were to create a model where everybody had access to good food, gym, right, trainer, free of cost. Let's say the government paid for that, because they want society to be healthy. It'd be interesting to see then how our society health would be.
Yeah, I feel like our allocation of our tax dollars and resources are significantly going the wrong way in different um, models because you mentioned last night at dinner certain countries that will pay people, or not pay people, they will cover their gym memberships. And I think that, even off the bat, is more of an incentivized program to get people to go to the gym if it's being covered for, maybe
Again, let's go back to why do we have a system? Why do we have a healthcare system?
to improve people's health.
Right. And so what does that involve? It involves what we talked about, whole foods, real food, movement, whether it be walking, exercise, you know, to add to that is access to the gyms, right? If we're gonna fight for pharma care or dental care, again, you're promoting a system that wants to heal or help people get healthy. Why aren't we subsidizing? People should have access to the gym. People should have access to real good food, right? If the system is designed to create health, right? Because then, with a healthier society, there's ideally less burden on the system and less cost to the system, then, right? And it'd probably, in the long term, compensate for those subsidies for the gym and the food, right?
Yeah, and it's not like rocket science to know that the correlation is strong enough to know that's probably causation where increase in obesity, comorbidities, uh, higher calorie consumption, less exercise, less movement, less steps over time has created a more strained healthcare system, amongst other things, of population. But the topic of this is that how do you make it things like better food options and gyms and exercise more accessible for people or
Hmm.
helping cover it, because however they're spending the $300 billion right now is not good. I don't know who's running their budgets. I don't know if they ever see this or not, but I hope they do. They need to fire them and get someone else in, um, because it's bad. And I know you're passionate about hospital food and
Mm.
talking about food in the hospital, and I want to segue into that because that is also an area where if you talk about what is healthcare and your definition of it, which I agree with, is providing health and um, making people improve their health.
Hmm.
And then you go to a hospital where you have LED lights 24/7,
Hmm.
no light structure for circadian rhythm. The hospital food is terrible, not nutritious, not healthy.
Hmm.
The diet maps that they're giving you is backwards. They prioritize carbohydrates over proteins and healthy fats. And it seems like, I don't think it's actually malicious in intent, by the way. I don't think the hospital boards are trying to make people sick and
Hmm.
make more money, but it kind of looks like it from the outside when you look at it, like, holy man, like, what are we doing here?
It's a system, right? Like, so it's part of the system. The hospital's part of the system. And yeah, I've always had a curiosity of the food in the hospital. Like, I spent time in the hospital as a young kid with appendicitis, right? And even now, like, what patients are fed, diabetics are still given ginger ale. Like, it doesn't make sense, right? So how do you, and other health experts have raised this concern as well as hospital food. Is it real food? Like when you get cookies and flavored yogurt and jello and it's not, and pop, like, is that real food? It's not, right? Um, you do see eggs and toast and sometimes other things that are real, but how is that going to help them heal, right? Because again, food is to fuel your body, to fuel your physiology, to help you repair things, to sustain those to sustain those things too, right? So yeah, I think there needs to be a revamp of what we give to patients as well.
Because you said something last night, and it makes perfect sense, but there's actually literature on this now. You said that people that go into surgery, if they increase their protein intake before surgery and after surgery, have much better surgical outcomes.
Yeah, they heal better for sure. Yeah.
And so for me, when I had surgery, in my small suitcase, I was in the recovery room floor for 5 days. And I had a big bag of protein powder, a
Mm-hmm.
protein shaker there.
Hmm.
Anytime like one of my friends came to visit me or girlfriend, I would always ask them to like shake protein powder for me. And that's because when I did the math on the protein, that the amount that I'm getting from the hospital, it was like under 50 grams a day.
Right.
And I was 200 pounds at the time with
Right.
a lot more lean muscle than I have now.
Mm-hmm.
So that's just an example of that. It's in the literature. We know it conclusively,
Mm-hmm.
yet the hospital is not providing it.
Right. Again, it's change management, right? 101. How do you transform a system or change part of a system, right? It takes multiple stakeholders. It takes leadership, right? And it takes awareness. And part of the stakeholders has to be the patient, right? And on the other end has to be the hospital board member, right? In terms of making that change.
So my grandfather, Jim, he's 84.
Mm-hmm.
He has, I don't know what stage it is. I don't think it's severe, but I don't think it's necessarily onset either of dementia.
Mm-hmm.
But he had a heart attack recently. He's definitely on his last days, and I went to visit him in Brockville.
Mm-hmm.
I don't know what the hospital name is there. So I went there and I visited him for the day, and they brought him a meal, and it looked healthy and good and whole foods.
Mm-hmm.
And I asked the nurse, I go, is this hospital food? She's like, yeah, it's really good here. And I shared some of my experiences being in from the ICU to
Mm-hmm.
surgery rooms over the last few years and my experiences. And she said, yeah, a bunch of the staff here, this is again anecdotal, but a bunch of the staff here made the board directors or
Mm-hmm.
stakeholders or people that make those decisions eat the hospital food and try it.
Interesting.
And then they changed it. So that hospital now has like it was good. It was like lean protein. There was veggies on there, brown rice. Like it looked like it was a nice,
Mm-hmm.
okay, significantly better than what
Sure.
usually happens.
Yeah.
And even that to me would be a dramatic increase. So how the hell is Brockville Hospital doing that?
Yeah.
But Kingston General Hospital and the Ottawa Civic aren't doing that.
Yeah.
I don't get it. Why is that?
Again, it's change management. Somebody has to take a lead and say, hey, if we're trying to get people better and heal, this nutrition is, inappropriate.
So individual hospitals can make different decisions on what food to give patients.
Yeah, that's our system because the individual hospital control the cost, budget, etc., etc.
Who decides what food is given out? Who's the final stamp of approval at a hospital?
I wouldn't know the
I'm not looking
exact
for
answer.
I'm not looking for names. I'm just saying like
I
the
wouldn't know
role.
the example, but it'd have to be again if it'd probably be the dietary department and probably somebody in the administration for sure.
Hmm.
There'd have to be discussions with that.
Do you have to be a physician to be in those roles?
In terms of the administrative role,
Yeah.
no. There's a mix and mash of people who are um, part of the administration and the board.
So
There's always representatives for sure. Yep. And we also have a medical advisory committee as well. Most hospitals have a medical advisory committee.
so this is in theory that a medical advisory team in combination with the admin have meetings to make decisions on the food in hospitals and then roll it out.
It can be a topic to be discussed for sure. Yeah.
And amongst those conversations, and I'm not Canada, by the way, like
Sure.
hospitals in the States and other countries with really good healthcare, it's pretty universal that the food is pretty bad.
Yeah.
So all of these people in these hospitals are leaving that meeting with approving food that's going to patients that's not good.
If it's the topic of discussion, yes. If they haven't
Holy
brought
shit,
it,
man.
if they haven't brought it up, then nothing will change, right?
And the craziest thing about it to me,
Yeah.
of it all that grinds my gears, is if you just got 12 gym bros with good physiques in that room,
Mm-hmm.
they would roll out a significantly better diet for patients than this medical advisory team and admin. Like you said earlier, you learn more about nutrition from a gym bro than you did from medical school.
100%. Yeah.
Like, I know.
And now more because of access to social media, Instagram, watching videos on up to date, things that are good for your health, nutrition. So you got to do your own learning as well after you've kind of been stimulated to learn about it.
Yeah, because I always use the example of Huberman on Getting Morning Light.
Mm-hmm.
No one in the world, maybe not no one, very few people in the world, and no one that I've ever known personally, ever talked about that or knew about it. And
Mm-hmm.
he obviously became this global famous scientist preaching that.
Mm-hmm.
And now so many people know about this morning light situation.
Right.
So I think that's definitely been one massive net positive of
Mm-hmm.
the social media sphere. And I think I told you this, but when I went through the surgery process and firsthand what that can be like for people, when I came out, I had really bad sleep patterns
Mm.
and habits.
Mm-hmm.
And I couldn't get it on track. So I had an appointment with a sleep doctor, and she recommended that I get the 10,000 lux light
Mm.
because I couldn't use my legs, so I can't get outside.
Right.
So I would just turn that light on when I woke up and looked at it or looked close to it, my peripheral very closely. And that actually significantly improved my sleep. I actually started getting, over
Amazing.
time, I got sleepy at nighttime
Right.
and earlier and earlier and earlier.
Hmm.
So I don't know. I just find like this whole thing unsettling that the hospitals for healing and health, but the lighting in the situation is so set up poorly that my sleep gets dysregulated
Yeah.
as I'm leaving surgery. And of course, I now have blood flow in my feet. I am very grateful for that.
Mm-hmm.
And it's amazing that I didn't have to lose $100,000 for it.
Mm-hmm.
And that part of the medicine is phenomenal. But when we're talking about the word health, I don't think that encompasses bad food and bad lighting and pumping me full of drugs.
Yeah, there's a lot of factors that go into health, right? And you've touched on a few of those areas. And but again, I think it's how you feel your body throughout your life. It really comes down to that, right? In terms of being healthy, staying healthy, preventing illnesses, chronic illnesses, and and I'm talking about things that are reversible. I'm not talking about key things you have no control over, right? Um, but yeah, part of our health is in our own hands, right?
Yeah, because I like to point a finger and on a healthcare system for sure, but I also will do the same with society.
Mm-hmm.
Because Naval has a really good quote where he says something around the tune of a fitness trainer can't make you fit, a doctor can't make you healthy, a guru can't make you rich, only you can.
Yeah.
Something to that tune. And it's true where it's, I think a lot of people, hopefully, that end up listening to this also realize that Rav can't save you. He's not beside you every single day,
Mm-hmm.
choosing what you put in your mouth,
Mm-hmm.
choosing how you move your body. So I always think like if you're gonna blame someone or point your fingers, the first thing you need to do is the mirror, and then
Yeah.
move forward with that.
Yeah.
So if you're getting bad health care, but you're not exercising, you're overweight, and you're complaining about it,
Yeah.
it's like, well, you're not. The reason why you're even in that situation is because you made bad choices. So that's your
Yep.
problem.
Or choices that they were accustomed to growing up because of the culture, right? And
Mm,
they don't know any better, right? Like if you're growing up eating craft dinner, you're not going to know any better that it's not good for you, right?
right.
If you're growing up and having McDonald's once a week, that's the culture your family's established. You won't know any better that it's not good for you, right?
Right.
And I don't know if you've experienced this, but the more you eat these foods, you get accustomed to it, right?
Yeah.
And you don't feel the detrimental effects from it. Once you stop eating, I think we talked about this earlier, once you stop eating these types of foods and then reintroduce it, you're like, this does taste artificial,
Yeah.
right? Or not real. So again, I don't think it's about blaming. I think it's about educating, like you talked about, like self-reflect. I'd call it self-reflection versus blaming, because blaming takes a negative connotation. I'd say self-reflect. How did you get to this point? Okay, going forward, what kind of things you do to prevent it from progressing and getting healthier,
Right.
right?
Yeah, that's fair.
But I think blaming has a negative connotation and can hinder maybe progress, right?
You're doing the. Are you familiar with the Spider-Man meme, the famous one that went around a couple of years ago? So it's three Spider-Men all pointing at each other,
Yeah,
and I feel like you could do that photo with like healthcare,
yeah,
admin people, and patients,
yeah.
or not regular, but society that's outside of those two categories of doing this
Mm-hmm.
a lot of the time.
Yeah.
And I'm in a lot of conversations through my last career, and I hear all sides of it where people are complaining about healthcare, but they're unhealthy, right? Or doctors that are complaining about some of the things that the healthcare system is doing, admin, but they're not speaking up against it or trying to create, I don't know, go get some signatures in the hospital. I'm sure it's very easy to go get in a big hospital in Ottawa to get a couple hundred signatures from nurses and doctors to say change the food.
Sure.
I'm just trying to think of an example. Got it. And we're back. He goes out and we got to go to the washroom. So I want to touch one more thing on the food situation. So if you
Mm-hmm.
were in charge of a hospital,
Mm-hmm.
what would you, or what would be two or three things that you would change first, right up, like as quickly as possible?
In general,
Yeah, for
I
the
would
whole
introduce
hospital.
I would introduce AI for sure. With the AI um, quote unquote revolution, I think industries and big corporations outside of health adopt it already, right?
Mm-hmm.
But incorporating AI, whether it's to facilitate physician workflow or helping triage patients in terms of what tests they need when they come to emergency.
You were just out, Hugo.
You were just outside. Um, so that'd be one thing. I think the food for sure. And I think you can use AI in catering what each patient requires, right? In terms of their nutritional requirements while they're in hospital. Based on you have their age, you have their gender, you have their weight, height, uh, and you know why they're in hospital. So you can cater what their food should look like while they're in hospital.
Right.
And that can be done through AI, and that can be uh, something they generate on a daily basis. This patient had surgery. These are the requirements during a sort of a catabolic state after having surgery. These are the requirements for this patient, and tailor meals around that.
I have a lot of questions about AI, so maybe it's easier to go through the first thing that you mentioned and scale it. So a system where that you plug in the information, vitals, surgery, age, and then it'll spew out within what, 2 seconds, I guess,
Mm-hmm.
um, what they should be consuming or eating.
Yeah, just like we calculate macronutrients, right?
Mm-hmm.
How much protein, carbs, fats in terms of grams we should, take every day to reach our goal. If your goal is to maintain weight, lose weight, gain weight, right?
Right,
You're going to have different requirements, and that'll be based on your activity level, age, gender, height.
right. Got it. And
So why
then
can't we cater that to patients in the hospital?
do you think it would be too hard to do so many variations for each patient for food?
Probably,
Yeah.
but it doesn't mean you have to have different proteins, right? It's just the amount of protein, carbs, and fats is going to be different.
Oh, yeah, that's fair too.
Not necessarily the food type.
Because if it's all that day, just chicken breast for the protein and broccoli and rice,
Mm-hmm.
you can just scale the different sizes and
Right.
move it based on. And again, it doesn't have to be this, in my opinion, it doesn't have to be this exact science
Mm-hmm.
where the nurses have to weigh out the vegetables and the rice to an
No,
exact gram.
no,
Because if you're just giving, as an example, chicken, some broccoli, and rice to each patient, that's significantly better right off the bat than what
mm-hmm.
they're currently getting
Mm-hmm.
with Jello and Wonder Bread.
Right.
So AI would stream a lot of
Mm-hmm.
that work and that time.
Yeah, or even before AI, just revamp the nutrition we give to patients, right?
Mm-hmm.
But I think AI would help make it easier.
Do you think AI could help with emerge wait times?
um, well, I think AI has the capacity to do a lot,
Mm-hmm.
right? It's how you actually use it and implement it for whatever goal you have for that system. Anything can be used to change something, right? AI can be used to change anything. But it all depends on your input, your goal for that change, and it can probably be achieved.
Right. Would it be too risky to have AI triage patients?
So if you think about patients coming in, they come in with certain symptoms. You do their vitals, so you have data points. Those data points can easily be put into AI and what are the next steps, right? Um, because us as physicians, we have data points in our head. If these patients come in with these type of symptoms, these are their vitals. We have an algorithm or inherent results that pop up in our head, right? So I don't think there's any more different than using AI to do that. And AI probably has more data points that can cross-reference. So that initial, I think, interface, patients presenting to emerge, certainly patient coming in an acute setting or acute condition, you can't really do because you know where they're going in terms of triage. But all the other cases that may have a bit of waiting, you can triage to the point where using AI can tell you these are the next steps, and you don't maybe need a doctor to initially see them. You just get those tests done, and the doctor then comes to see them, right? And then give their decision and assess them.
Got it. So if I go to Emerge and they do my vitals and information, you as the Emerge doc get that information from the nurse, and you decide where I'm triaged. Did I get?
I'd put it into AI, and they can tell you what tests you need initially.
But I mean, sorry, I meant like right now. That's how that works.
That's how that works.
Yeah, I got it. So the thing about that is,
or the nurses may triage based on your symptoms and the criteria they have.
I guess a better question would be, are people in Emerges triaged sometimes without the person who triages them seeing them in person?
I'm not sure of the specifics of that, but a nurse certainly sees them at triage for sure.
Yeah, got it. What are your thoughts? I'll just say it. What are your thoughts on people that actually don't need to see a doctor?
It's all subjective, right? You may have a symptom and feel you don't need to see a doctor that day. Other patients may have a subjective need to see a doctor that day. So it's complex in terms of patient outlook, how they feel, their experiences, in terms of needing to see a physician or primary care or emerge doc that day.
Yeah, because I'm trying to think using AI all out would be tough because in the sense from, like for me, I presented all of these symptoms, but normal MRI with contrast, Doppler ultrasound, the list, sports medicine doctor did, compartment syndrome testing. I did a whole slew of really good medical grade tests, and it took an angiogram at the very end to find it. So if you plug in everything to AI and they're like, oh no, he's good here, he can just move on, then I might have missed out on the part where the doctor saw my emotion or feeling side of things.
100%, but you're going through a process. It's not this initial triaging, right?
Yeah.
And I think the experience of a physician can use AI as an adjunct as well, right? It doesn't have to be all and end all, where you solely rely on AI.
Do you see physicians using AI now?
Oh yeah, it's becoming.
Is it a faux pas thing to say, or is it?
It's more common use, like looking up things you have never seen or experienced, right? Again, AI probably has more data points and all, quote unquote, knowledge than we do.
Of course.
Right.
I mean, I'm an outside perspective because I'm not a doctor or surgeon, but I don't think there's anything or anyone that has more knowledge on their profession than an AI would from an analytical or study perspective. Like AI can pull up every single study on ulcer colitis ever done in seconds. Where there's no way that you can remember every single study that's ever been published.
Not at all.
So that makes sense. I feel like AI would help a lot. And another one too, I talked to you about it, but the gentleman in the States that the radiologist said things were good. The gentleman put it into ChatGPT and it found something. They went back to the radiologist and the oncologist, cancer, and they were like, oh, we missed that. You have cancer. I think it was like stage 2 or something. And they did the treatment. So the AI caught something that the radiologist didn't. And then last night you said there's been times where the radiologist sends something to you and they miss something and you catch it. But I feel like, wouldn't AI be significantly better for reviewing images? Because that's not a feeling thing. That's just the image, and the AI can pick up way more than the eyeballs can.
Yeah, like I say, it can be used as an adjunct for sure for any physician, right?
If AI, in a hypothetical world, if AI did all of the review of imaging and spit out results to you,
Mm-hmm.
would that save you a lot of time?
Would it save a radiologist time or myself?
Uh, Anyone, we'll say radiologist. It would save a ton of their time, wouldn't it?
It would, but the thing is the accuracy, validity of it, right? So that would have to be taken into account. Like, are we solely going to rely on AI, or are we going to use it as an adjunct to confirm what we see?
Right. Like the
Because
radiologist,
we can't assume AI is going to be 100% perfect, right?
no.
Because they could overcall things.
But doctors aren't 100% perfect either.
100%. So I think using it as an adjunct, I think, would be an appropriate use for sure.
So having a combination of both.
Experience plus extra data and information.
Yeah. So what parts of AI would you implement in hospitals that would help the workload for, we'll just say surgeons and doctors, because that's your specialty?
Yeah, I think in terms of flow, documentation is a big thing. So I think helping with um, flow, creating consult notes, dictations. I think there are AIs out there like AI Scribe. There's another program called Clever Consult, which can generate a consult template note from a referral letter.
Got it.
So those kind of things that help with workflow uh, can be impactful because then it gives us more time to concentrate on other things rather than the documentation aspect of it. I think it could be beneficial in triaging patients initially at emerge. Unless they're acutely ill, then there's no real triaging. They just go straight to an acute bed, right?
Mm.
Um, there are places, I think, in the States that use AI for pathological slide analysis, x-rays, like radiology. Um, those are the areas I've heard of. So,
Is it because remember when I would see the surgeon leave and walk out, I would always walk by Dr. Hajar's, wherever the office is that
mm-hmm.
the door's open, and he would be talking into a microphone, which would be the recap of our meeting that goes
Yes.
to my chart.
Yep.
And I just was thinking to myself, like, if he's spending, I don't know, 5 minutes after every single patient
Mm-hmm.
in a year, how many more patients could he see? Or how many patients that he does see could he give better quality to and more attention to?
Yeah.
Because what's the average time do you think a surgeon spends with patients in clinic, like before they get surgery or full diagnosis?
For consult, probably 20 minutes. For follow up, maybe 5 to 7 minutes.
Just 7 minutes. That's not a lot of time.
But again, that's an average. You can't, it doesn't mean every patient's had surgery, right?
Right.
It could be just a colonoscopy, one polyp taken out. It could be just a follow up from recommendations you made from the previous consult, right? So it's just an average of time, basically.
What about the admin process? Because I feel like AI would be so much more helpful in terms of scheduling and getting documentation and information and disseminating it faster. Because I feel like in the hospital, there's so much paperwork you probably have
Mm-hmm.
and documents, but AI can just do all of that within seconds.
Yeah, and I think what would have been easier is if all the hospitals in Ontario had the same electronic system,
Right.
rather than having third parties to connect or look up results at a different hospital, right? So if every hospital had the same electronic medical record that they use or records that they use, it'd be easier to transfer information, right?
So how do you, so if you get a patient,
But that's not the case. That's not the case, and so now there's third-party interfaces where we can actually look up the patient within Ontario and what they've had done at different hospitals.
yeah, but with AI, you can just type in their name and boom, everything just pops up in a second.
Yeah.
All their visits of their whole life,
Yeah.
symptoms, situations.
Yeah.
Because when I saw,
Wouldn't it be great if our health card had all our information on it, and wherever you went, they scanned it and they could see all your history?
right, because I'm not hating on the guy because I really enjoyed my experience with him, but my surgeon, one of the conversations I had with him, I mentioned that I saw a neurologist
Mm-hmm.
to rule something out,
Mm-hmm.
and he didn't know about that. But it's in my records. And I'm
Right.
not hating on them, but if you're a high volume surgeon in a high volume city, like, yeah, maybe like these guys generally just don't have the time in their work week to
Mm-hmm.
look through everything. And that's an important part to know about my process.
Mm-hmm.
But I think AI would be able to filter out what information from previous appointments does this guy actually need or
Mm-hmm.
want to
Mm-hmm.
know about. He doesn't need to know about my family doctor visit 3 years ago, but
Sure.
when he saw a neurologist about this 6 months ago,
Yeah.
that's really prevalent.
Yeah.
So why do you think the hospital system is so stubborn about not adopting AI like the rest of the world?
I don't think they're stubborn. I think they're just not aware what the capacity can be with AI.
Hmm.
Like you need to have that initial discussion. AI is out there. How do we actually incorporate it, and what are the steps to actually incorporate it efficiently so it's not affecting the existing workflow, right? Because you can't stop working or taking care of patients or documenting, and we have to do a trial period where we see, oh, does this really work well or not, right?
And the trial period,
So it can't be like we should adopt AI. No, it can't be that simple, right?
yeah, especially when you're dealing with humans in life and death situations and
And
ailments,
it's a whole hospital. You're transforming a whole hospital. That's a big change.
and then training the 7-year-old surgeon to use it who's going to retire soon and doesn't want to adopt it.
And some physicians quit because we went to electronic medical record from paper charts
Really?
because they didn't want to learn it.
Yeah. I didn't think about that. Especially the guys that are on the fence about retiring and they have enough money saved where they can retire.
Mm-hmm.
That might be the thing that puts them over the edge to just retire.
Yeah. So change management is it's possible, but you got to do it strategically so people adopt it, right?
And layered, yeah.
Right.
Because there's so many staff in the hospital. Yeah, that's interesting. Yeah. Hopefully they get AI soon because it's are you what is the hardest surgery you've ever done?
The hardest surgery I've participated in as a trainee would be probably a Whipple, where you take out part of the pancreas.
And
It's
why is that?
probably 8 hour, 9 hour surgery. It involves so many parts, anatomy parts, where you take out part of the pancreas, part of the small intestine, part of the bile duct, and then you have to reconstruct that all.
And that's GI surgeons that do that?
Hepatobiliary surgeons. Yeah.
Yeah.
Toughest surgery I've done, they're always emergency ones where it's either a burst bowel, right? And there's poop everywhere in their belly. Those are probably the toughest ones. Or they have chronic scarring of the bowel and it's stuck to everything,
Mm.
to vital things sometimes. Those can be challenging for sure.
Do you have moments of regret based on decisions that you've made during surgeries?
Good question. Personally, I haven't. There's three things I learned when I was training. Three pearls my mentors taught me. One, never leave a surgery in doubt, because then you didn't do the right surgery. Two, there should be no surprises, ideally in elective surgeries, otherwise you didn't do the proper workup. Three, a good surgeon knows when not to operate. And those three things have always stuck with me. So I'm always conscious of if I'm doing surgery, I don't want to have any doubts when I leave. Yeah. Because if I think about it, then I should do it.
How do you mentally prepare for doing surgery?
Well, you have to know your patient, what the diagnosis, what workup has been done. So you have to know wholeheartedly what the patient's there for. And then I always play the surgery in my head, like mentally. Even though I haven't done it yet, I just go through the steps mentally with images in my head, going through the steps. Yeah, and just take some nice deep breaths before I go in.
Got it. Do you get up like extra early on those days or
No,
just your regular routine?
regular routine.
Do you ever get nervous for surgeries?
Not that nurses have told me.
Got it.
I don't feel any nervousness.
Were you nervous near the start of your career at all?
In some emergency cases, yes, for sure.
So if you get a call and you're on Emerge, or you're sorry, you get a call from Emerge and
Mm-hmm.
and you race in, how much time do you have before you have to um, cut that person open and start making decisions?
Depends on why they're there. Yeah.
Is there times where you don't have enough time to get certain test results that you would prefer to have before doing that surgery?
Yeah, for sure. Yeah. You base it on clinical examination and what their vitals are, and sometimes you can't wait for testing.
You just gotta go.
Just gotta take them and explore.
So I'm guessing those would be the ones that across the board in surgery have lesser success rates for sure.
Yeah, usually the complications are higher and results are poorer prognosis for sure.
When you're on call, you do a week at a time, right?
We do a week at a time. Yeah.
Yeah. Do you have a different energy or mental state when you're living your day-to-day life knowing that you're on call?
No.
Everything stays the same?
Mm-hmm.
Got it.
That won't change anything. In our practice, we don't do any elective work while we're on call because it's hard to be in two places at once. But otherwise, it's a work day.
So when you're on call, you're not at the hospital at all. You're just maybe here doing your thing, working out.
Well, the day usually starts. We have to round on inpatients,
Hmm.
um, and then we just wait for any other calls that come in for consults or anything emergent.
And then sometimes you get called in at 3 in the morning when you're sleeping, or
Yes,
got it. Do you have to live within a certain radius of the hospital?
20 minutes.
And the hospital makes sure and checks on that?
I'm not sure how they verify it, but that's the recommendations within 20 minutes.
Hmm. Interesting. So, do you ever have emergency surgeries where you have to collab with another surgeon?
Yeah, happens. So gynecological surgeons sometimes, if the bowel is stuck to the ovaries or the uterus, the urologist if the bowel or inflammation is involving the tubing that goes from the kidney to the bladder.
Hmm.
Rarely orthopedic surgeons, more so if there's a what we call quote unquote flesh eating disease of a limb, leg, or an arm that we need assistance with.
And then, are there programs in place for nurses and doctors to deal with mental trauma from what they go through and experience in the workplace?
Yeah, there's debriefing sessions that can be arranged for sure.
And what does that look like?
Whoever's involved in that case or scenario and meeting with unit leaders or chiefs of the services, chief of staff maybe sometimes,
Hmm.
or VP clinical, which is usually a nurse, um, patient safety representative. Yeah.
Got it. And then we talked about it a little bit last night, but you were talking about how working those 18, 24-hour days
Mm-hmm.
as a medical student was beneficial.
Mm-hmm.
And the other person at the dinner table was mentioning how it's maybe not inhumane, but it's crazy that they make medical students go through that. And now there's some changes that have happened where that happens less.
Mm-hmm.
But a result of that is that over the course of your residency or surgical training, you're going to spend less time in hospitals and see less patients.
Mm-hmm.
And although being up for 24 hours isn't ideal,
Mm-hmm.
there are times as a surgeon or in Emerge where you have to do many surgeries
Mm-hmm.
and you're going to be up for that long.
Mm-hmm.
So when you told me that, I was kind of worried. Like, Does that mean some of these doctors are going to not have that experience or training of what it's like to operate after being awake for a long time?
Yeah, they may not have the experience for sure. And if you think about it, those rules during training, they stop when you become a full-fledged practicing surgeon because those rules don't apply anymore.
Right.
Like, because the real world hasn't adapted to that change, right? And physicians are considered essential workers, so we don't fall under the labor laws,
Right.
right? So yes, I think well-being is important. So in training, residency training, they've made changes to help with that. It can certainly lessen exposure to experiences. Whether that correlates 100% that they're less experienced or going to be not as good physicians or surgeons is hard to know, or less knowledgeable. But then those wellness balances, don't carry over into when you're practicing as a surgeon. You have to sort of set your own boundaries. If you're tired and can't do surgeries, then you should have the courage to ask your colleague, hey, can you do the surgery for me? Or can you do my call tomorrow?
Got it.
I think there has to be that environment culture where you're not criticized for asking for help, right? And
Mm.
that's a culture that's hard to change in medicine because it's such an individual journey, right? You're fighting to get into medical school, fighting to get a specialty spot, fighting to get a job at a hospital. So it's a very individualistic journey. And then to shift it to setting boundaries where, I can't do this call this day. So there has to be a change in culture where, your colleagues have to reciprocate or help out, right? And it has to be reciprocal as well.
Yeah, that makes sense. Mm.
Because we're human, we have capacity, right?
Yeah. What is your thoughts when people reference burnout with healthcare workers? Because I hear a lot of individuals saying that nurses and doctors are experiencing burnout
Mm-hmm.
because of their jobs.
Yeah, it's a common thing. It's hard to isolate it just to work because people have other parts of their lives we don't know
Mm.
that could be contributing to the burnout as well, right? So it'd be hard to isolate just work itself and they had nothing else going on in their life that's contributing to burnout, right? Because burnout's just mental, emotional, physical fatigue to the point where you can't function or don't want to function. And to say it's just from work, that'd be a hard study to do.
Right.
But because most of our lives and most people, work is our main thing, you can kind of correlate or say, yeah, this has a significant contribution to that.
Yeah, I guess my beef with, I'm not saying healthcare workers, but the word burnout in general is if you're someone who's in that related field, but your lifestyle choices outside of work aren't ideal,
Mm-hmm.
then the efforts that you spend at work are going to be more stressful or more impactful.
Mm-hmm.
And your capacity is going to be less because maybe you went out and partied, or you're not sleeping well, you don't exercise, you don't eat well.
Mm-hmm.
So this whole thing of pointing the finger at one individual thing, one healthcare, one profession for burnout seems to be a bit like misguided or disingenuous.
Yeah, it could be based on like what I said. Like you have to look at the whole kind of holistic part of their life, right? What else is happening in their life that may be contributing to it? And again, burnout is subjective, I feel, because we are all unique individuals with different perceptions, experiences, tolerances. All those things kind of give you an outlook on life and experiences and how you face experiences and your attitudes toward them.
But I would want a surgeon that went through the ringer a bit
Mm-hmm.
because they proved through survival of the fittest that they have that capacity, because that's how it works in every other, maybe not every other, but most professions or most sports.
Mm-hmm.
What ends up happening is the higher you get up, the better the average people or in that field are, or
Mm-hmm.
that level is at,
Mm-hmm.
whether it's like high school football to the NFL. And it's supposed to be hard. And you need to show that you can perform long hours because you're applying for a job that's going to sometimes require you to work long hours.
Mm-hmm.
So I don't know. In my head, I just feel like it takes away, like the not having medical students do the odd 24-hour shift. Like it just takes away from that process because you have to have a very high capacity to be a surgeon.
Mm-hmm.
And we should be testing that with them during residency. And I'm not saying it's like Navy SEAL training where
Mm-hmm. Mm-hmm.
we're making them, but once in a while, it's not going to kill you. Like Alex Hormozy has that one quote where it's like, a few nights with less sleep isn't going to kill you, and he keeps going kind of through the thing. But a great story and experience lasts forever. But yeah, I just feel like you're almost watering down the requirement for surgeons by doing that.
Yeah, and I think the theory behind it is the liability nowadays, right?
Hmm.
There's more and more concerns about liability in a lot of fields. So lack of sleep and you're still working. Are you at the optimal level of cognition, performing a skill, thinking about patient care? Um, I think that's what's sort of important in this time and age, right? And I think that's why there's sort of cutoffs in terms of working hours.
Yeah. Yeah, and I think all those things are clearly important. I'm just thinking about those more, maybe not unique, but rare experiences that you have as a surgeon because you're going to
Mm-hmm.
be in for a rude awakening
Mm-hmm.
if you've never done a 24
Yeah.
and then you become a surgeon one day, you're on call and a bunch of happens.
Mm-hmm.
Like, what was the most amount of surgeries you've done in a row or in a day?
8.
Right.
Yeah.
But if you've never, maybe not eight, but if you've never done long durations, I just feel like there's a gap there for sure.
Yeah, and I think that's why the culture needs to be established where if you don't have that capacity, then there should be no boundaries to ask colleagues to help you out.
Right.
And that's a shift in culture that is happening, and it's slow, but because the demands in healthcare have increased as well, right?
Yeah.
So everybody's kind of working over capacity, probably. Hospitals are always over capacity, and that just reflects on the system where if hospitals are over capacity, the workers are going to be over capacity in terms of their work, right?
And how do you get more nurses in then?
So a lot of nurses are actually leaving, the studies show,
Yeah.
especially in a certain age bracket. Um, they're leaving sort of the hospital setting.
So how do you get more people to be interested in nursing?
Yeah, it has to be part of the revamping of the whole system, right?
Yeah, exactly.
Because the demands are more, like we talked about, patients have more comorbidities, on multiple more medications to deal with. Um, I think expectations of what needs to be delivered by patients for patients has increased.
Right.
Frustrations with wait times. Uh, so now you're dealing. Now you sort of have to be caring for somebody who has multiple comorbidities on multiple medications. Expectations from that patient have increased over time. Expectations from family members, caregivers have increased over time because their frustration is going through the system. So it kind of carries over and boils over. Um, and I think we're not trained for that
Right.
because we've never experienced it 10, 15 years ago.
Mm.
So how do we build that capacity? We can hire more nurses, but nurses are leaving this kind of environment because they're looking at their own well-being. There's a saying, who heals a healer?
Right.
I think there's a book on that. And I think that's the state, you know.
I know a lot
New
of,
graduates in primary care are not going to have the same patient load as a primary care doctor who graduated 30 years ago.
hmm,
A few thousand patients back then they would carry versus 500 to 700 maybe.
yeah.
So you need more doctors to care, many more doctors to care for more patients, increasing population, aging population.
So it's a a storm of significant variables that are all happening at the same time.
Yeah, exactly. And there's limited resources to train. So it takes at least 6 years to train primary care.
Right.
So how are you going to catch up?
Which comes back to the original part of the conversation that it's more important than ever to take care of your metabolic and overall health to avoid having to risk going through the healthcare system and waiting for a long time.
Correct. And you'll hear patients, complain about wait times. Um, and you're right. It all comes back like, what efforts are you going to put in to improve your health, right? And again, I'm talking about things that you may have some control over.
Yeah, of course.
If you develop a cancer randomly, that's kind of bad luck in life. Or if you develop type 1 diabetes because of a viral illness, again, you don't have control over that.
Yeah, that makes
If you
sense.
develop MS, again, are there environmental factors that trigger it? I don't know. I'm not an expert in that. But sort of things like that that come out of the blue, you have no control over. But I'm talking about, you know, things that you may have control over.
Right. Few more, but then we'll wrap up. I'll take up your whole day. The what is how do I say this? So, as a society, we've grown immensely from a technological standpoint
Mm-hmm.
and scientific standpoint.
Mm-hmm.
In the same time frame, our metabolic and overall health has gotten significantly worse.
Mm-hmm.
And I mean, obvious ones is less activity, cell phones, people just stare at their phone all day and doom
Mm-hmm.
scrolling.
Mm-hmm.
There's a lot of reasons for it. So, did what parts of Western medicine do you think are undoubtedly a net win for society that are certainly saving or extending people's quality of life?
Yeah, so I think the surgical field has a big impact. So, like we talked about, somebody comes with appendicitis, you take out the appendix, they feel better. Gallbladder inflammation, take out the gallbladder, they usually feel better. If they have a skin cancer, you take it out, there's less worry that, there's a cancer on their skin. So I think the surgical world has had a big impact. Um, Acute treatments like antibiotics for bad infections, um, thrombolytics, so busting clots that cause strokes or um, clots anywhere else, have been beneficial. So again, those kind of things, acute things, I think have made a big impact in terms of the care. Uh, I think what needs work on is, again, I think you have to realize, I think everybody has to realize inside what kind of journey or life do you want? And how does your own health, play into that or part of that? I think people have to really reflect on, what kind of life, what kind of health do I want to be in to achieve that journey or that life? As we talked about, it takes, a major event for people to realize, okay, I need to stop smoking, like after a heart attack, or if they lose their foot, okay, I need to really be diligent about controlling my diabetes, right? So it takes a drastic event or a loss uh, for people to change sometimes. But how do we get people psychologically to change before that happens?
It's interesting because self care, self health care and hospital health care are both very similar in that, for the most part, they're reactive,
Hmm.
right? And if people are going to continue to have self health care in a reactive posture, then they're going to continue the same trend of needing reactive
Hmm.
care.
I think a big impact to the system or our healthcare system would be to prevent people from getting unhealthy,
Yeah.
right? Developing the chronic diseases, developing obesity. I think that would have a big impact, especially the incoming generation. Um, and then step by step, getting people who are unhealthy with some reversible disease, getting them back to sort of a healthier state and not sustaining their health with medication. It's amazing how many people say they're healthy, but they're on like multiple medications because they feel good, right? Doesn't mean physiologically they're healthy. They're only feeling good because they're on medications to feel good.
Yeah, you remove the medication, and then so it's interesting because my mom always has a good one where that if you have like nausea or fever, and then I go and take a bunch of gravel and Advil to help with that, she always ushers me not to
Mm-hmm.
because my body is keeps the score. It's giving me a sign that something isn't right here.
Mm-hmm.
And by taking medications, you're just suppressing that feeling, like
Mm-hmm.
opioids, for an example, and then you don't actually get to the root cause and heal anything. So it's again just an alignment of the word reactive across the board. Because for me, the last, I would say 2 months before surgery and 6 weeks before I had the diagnosis,
Mm-hmm.
I made a decision to finally go on opioids because of the physical nature of my job
Mm-hmm.
and the symptoms I was having. I wanted to earn a living. I wanted to be there for the team that I loved
Mm-hmm.
working with.
Mm-hmm.
So I got a prescription of hydromorphone, which is 1 grade stronger than Oxycontin, for people
Mm-hmm.
that don't
Mm-hmm.
know. And when it was a very small dosage, which just ended up being, I think, 4 to 5, I think it was 5 milligrams a day.
Mm-hmm.
So I would take one and it would dramatically change my shift.
Mm-hmm.
I didn't have this. I was happier, but I don't necessarily think I was happier anecdotally from the euphoric effects. I just thought I was happier because I didn't feel
Right.
the pain, so it made me happy because I'm like, oh, I'm out of pain for once, or not have less pain. But you can see how that trap long term is can happen in that analogy across the board, where you're taking this opioid, you don't feel the thing, so then you keep plucking along.
Mm-hmm.
But if I never got the surgery and fixed the root cause, but you can apply that across the board.
Mm-hmm.
And I think opioids are very beneficial potentially for acute things, like if you're going into surgery and
Mm-hmm.
you get fentanyl. Or
Mm-hmm.
so when I came out of surgery, I had fentanyl, ketamine, and hydromorphine. And yeah, they just cut me open. They were just moving my friggin' arteries around. It makes sense. But I also think with opioids, this epidemic I guess we're in is, it seems weird that we're treating chronic pain through opioids outside of terminal illness.
Mm-hmm.
Do you think opioids are overprescribed?
Yeah, I think that's been proven, right?
Yeah.
Opioid crisis, right? Um, and again, studies have clearly shown Tylenol, Advil are much better in terms of pain management than opioids. And I think it's more the acute short term that it can be beneficial. Um, when we do surgery, minor surgery, hernias, gallbladders, appendixes, we always advocate take Tylenol, Advil for next few days, and if you need something stronger, take it. Otherwise, don't fill it. And most patients are fine with it. We used to routinely in training 30 tablets of a narcotic, right? Now we give like 10. And a lot of the times patients don't even use that.
Hmm.
So it just proves to us, okay, we overestimated what patients needed for after surgery. And two, we're realizing most patients don't even fill the 10 tablets. Mind you, some surgeries have gone to minimally invasive, so the incisions are much smaller. Okay, so there's
Right.
going to be less pain. The use of local anesthetic. all these things kind of contribute to the decreased use in opioids or narcotics. And it just proves that Tylenol and Advil can work for minor surgeries. You don't need opioids for that.
Because
Some surgeons don't even prescribe opioids for minor surgeries.
interesting. Because I find I can see cases where you have a terminal illness, or
Mm-hmm.
and you take higher dosages of stronger opioids like hydromorphine for just quality of life. Like you have 6 months left, you want to enjoy some hikes and walks with your family
Mm-hmm.
and moving around with them. Like I get that. That makes sense. But I just think the opioid prescriptions for I think a lot of them are it's overprescribed and it creates bad habits. And people end up getting I'll close the door in a second. People get used to the substance or the feeling of it.
Mm-hmm.
And when the opioid prescription runs out, it's not like they're just done. You can go, then they start trying to find different ways of getting
For
it
sure.
illegally, and it just creates this whole stem.
One thing I realized over my career is less is better.
Right.
So less pain meds needed. You realize most patients are fine.
Mm.
We used to do a lot of things to prepare patients for surgery during and after. And over the years, I've cut a lot of things out that didn't make sense or add value to the patient. And it's made no difference in terms of increasing complications or morbidity, but actually it's improved their recovery. So sometimes there's a lot of things we do in medicine because that's the way it is or was, and never reflect on, do these steps or things we're doing still have value for patient care or recovery?
Right.
Because we stick to dogma because that's what works.
So I think there's benefit there as well. I'm not saying they're all bad, but I also don't understand why opioids are prescribed in pills that can be crushed.
Hmm.
Because some medicines out there, like Cymbalta, for an example,
Mm-hmm.
are like little beads.
Yeah, you can't crush them.
Yeah. But so do you know why they don't do that for opioids? I know you're not like an opioid specialist, but
Not sure.
yeah. Because I just feel like you're just creating, because the bioavailability of intranasal is almost double with,
Mm-hmm.
so then if you're prescribing if you're a family doctor and you're prescribing, I don't know, 4 milligrams a day for someone, and they start feeling less effects, so they start taking it intranasally. Now you have a patient not taking 4 milligrams a day, you have a patient taking 8 milligrams a day.
Mm-hmm.
I don't know. It just seems like it's a messy situation, and it could be solved if they just did beads like they do with Vyvanse and
Yeah, there's so
Adderall.
many factors in terms of prescribing practices. It varies amongst surgeons, amongst GPs, amongst pain specialists, right? Um, Again, it's that systemic change, like to change a tablet from the ability of being crushed to the capsules. It's a systemic change. And how do you do that? You need to get all the stakeholders involved. You need to get the pharmaceutical companies involved. Like, why are they creating the medication the way they are?
Right.
It probably has to do with formulation, stability of the medication, et cetera, which they would know, right?
Do you think there should be one uniform across the board for everyone?
Ideally, in healthcare, that'd be awesome for a lot of things, right? Like, why are there different companies making different narcotics? Like, why not just have one company make one narcotic? Why do we have multiple companies making antibiotics? Again, this is the corporate world where you want to generate income, right? So you want your own product. Just like electronic medical records, there's several companies, right? There's no one monopoly, and so it's going to be competitive, and you want your products to be different.
Yeah.
So it's not a simple answer in terms of just changing it.
Because hospitals don't make money, but pharma makes a ton of money.
Mm-hmm.
And yeah, we know it's evidence is out there, like Purdue Pharma and the lawsuits that have happened where they've had to give up billions of dollars
Mm-hmm.
because of fraudulent studies and information and
Mm-hmm.
the damages that Purdue Pharma did with the opioid epidemic and prescriptions and incentivizing doctors to
Mm-hmm.
prescribe more and they got a cut of it. And I just think, like anything, whether it's big pharma or tech world, doesn't matter. The more money that is available for people, the more people are willing to be corrupt or bend the rules to make lots of money.
I mean, again, you have to look at what's their goal, right? What's their inherent corporate goal for their company? Just like what's the goal of our healthcare system?
Right.
Um, and anything they do that aligns with it, they're going to do.
Yeah, because I don't think hospitals are in this camp by any means, because I do believe that nurses and doctors all have the right, most of them anyways, vast majority have the right intentions.
Mm-hmm.
But with pharmaceutical companies, if people don't need medicine, they're out of business. So I don't think it's very hard to connect dots there where
Mm-hmm.
I'm not saying all pharma is trying to keep people sick for it. I'm not saying that. But there is an aspect where these people that are making CEOs and stakeholders are making millions and millions and billions of dollars.
Mm-hmm.
They need people to need that medicine to make that money, right?
Yeah, they produce the product for a reason, right? And they produce it because there's a need for it. If the need goes away, then the product is no longer needed, right?
And then certain things are introduced and brought into the market quickly, and then other um, alternative treatments aren't, like in the psychedelic field with ibogaine or ayahuasca.
Hmm.
And it just seems so backwards in that sense because there's not as much money in some alternative treatments.
Mm-hmm.
So they don't offer them. And again, like I'm not, you don't have to be a conspiracy theorist, but you can just look at, for some reason, people look at pharma and they can't be as objective about it as other entities in the world.
Hmm.
And which is always a bit interesting for me, at the cognitive dissonance, because it's obvious that certain things are happening the way they are for profit and for money and for greed.
Hmm.
Do I think all medicines and all pharma is doing that?
Mm-hmm.
No. But if you can make a medicine more addictive or more depend, people feel like they need to depend on it more. In my head, if I'm a business owner, why wouldn't I? Right? If I own a restaurant, I'm going to make the food as best as I can so people love it and keep coming back.
Mm-hmm.
So if I make these medications that make people feel amazing and feel great, even if they don't solve the root cause, they're going to keep coming back.
Yeah. And again, in the end, it comes down to, we talked about that accountability piece, right? From ministry to the patient, and it has everybody in between, including pharma, right?
Mm-hmm.
So it really comes down to, what does the patient or person want for their life and journey and their health, and how do they want to change that? And if it means, if they're not concerned about their health or don't care about their health, then they'll rely on things that will make them feel better, right?
Yeah, I guess it's the same as when we talked about earlier with my friend Adam. But if you have someone that comes to you with ulcer colitis and you mention lifestyle and habits, and they're just not interested, they're like, no, I'm just going to keep living this way. I've lived this way for 50 years.
Mm-hmm.
I'm not going to change.
Mm-hmm.
You, as a doctor, then know that, okay, well, if I don't give them the medicine and they don't make these changes,
Mm-hmm.
I'm going to be, that's like malpractice. I'm leaving this person, maybe not malpractice, but I'm leaving this person with no option to feel better at all. So you're better off as a doctor in that situation to give them the medicine
Mm-hmm.
because they're not going to fix it. My position is that doctors, for conditions that are fixable or curable through without medicines, should be starting there with
Yeah.
people.
Yeah, there's options. There's always options. There's certain scenarios where there's only two options. For example, emergency surgery. We either do it or we don't, and you won't do well, right? So the scenario, there was, you know, two options.
Mm-hmm.
Other scenarios, there may be multiple options that the patient can decide on after discussing pros and cons of any of those options. So again, it has to be a frank discussion between physician patient, in terms of treatments, management, recommendations, um, before a decision is made, right?
I guess it's the same with me when I decided to stay on hydromorphone for part of my rehab with the doctor. It was an open discussion about that situation. Like
Correct.
it wasn't her dictating to me.
Hmm.
And by the way, I've actually had nothing but amazing things to say about my family doctor. I
Hmm.
think I won't say her name, but she's fucking phenomenal.
Hmm.
Um, Post surgery, she did an appointment with me every single week,
Mm.
and since then, every 3 weeks, she's been really great at advocating for me, and
Hmm.
I really appreciate her. But it's that conversation where it felt like it was a mutual decision about the continuing on the rehab.
Sure. There's certain scenarios, like I said, there is no mutual decision because there is and there isn't. Um, if somebody comes with a blockage of the bowel, I'm going to say you need surgery.
Right,
Now you can still say no, right?
but you
But
die.
I'm telling you, you need surgery.
Yeah,
There's no discussion in that because if I don't do surgery on you, then you're not going to do well based on experience, knowledge, skill, whatever. But sort of most of these other areas, yeah, discussion should be had in terms of, whether you want to do something or not.
because I feel like family doctors are more pharma experts than anything because they
Well,
prescribe more medicines across the board in ranges than you do.
for sure.
I'm not saying that's the only thing that they do, but they have on average maybe 10, 15 minutes with a patient,
Mm-hmm.
and they can, like a family physician in, we'll just say Ontario, the range of prescriptions and medicines that they're going to prescribe in a year has got to be significantly more than a specialized surgeon.
100%.
And they have to know how certain things counteract,
Mm-hmm. Mm-hmm.
which AI would be very helpful for
Yes, for sure.
and make faster because it can compile all the studies. And I also think patients now and individuals can use AI to help them in their day-to-day lives
Mm-hmm. Mm-hmm.
because they don't have time to, maybe not time, but if they have to wait to see a doctor,
Mm-hmm.
they can pull up an app and ask it a question that can assimilate all the information that every doctor has studied in the literature combined.
For sure.
And I'm not saying you're taking that as exact medical advice, you're making your own informed decision.
The thing is, you could get that advice, but understanding is a different level, right? Because you may not understand the terms or what this means or that means. And so, sure, you can ask AI, but you may not understand what they're actually telling you
Right.
or how to interpret it.
Exactly. Yeah, because I think at the end of the day, you're going to need doctors and physicians to make different decisions than AI would based on real life experience with certain rare scenarios
Yeah.
for sure.
AI has a role, it may replace certain things, it may just become an adjunct to certain things, right? Um, but that'll come through experience and trial and error.
It's always like
Where,
that
where,
one graph where um, hospital admin staff have gone up like crazy over time,
mm,
but the amount of healthcare like frontline or nurses and doctors has kind of like been pretty stable and gone up like a little bit.
yeah.
And so it's like technology is getting way more advanced,
Mm-hmm.
and we need just significantly more admin. Like it just doesn't make sense to me.
Mm-hmm.
And I think that there's a lot of money. I mean, wasted is a harsh word, but there's a lot of money that's not used properly. It is wasted. Where why would you, if you ran a company and you can pay 5 people 100 grand a year, why would you pay 10 people 100 grand
Mm-hmm.
a year to do 5 people's
Mm-hmm.
jobs worth of work? And with healthcare, we're talking about people's lives here.
Yeah.
Like you're going to have more money to invest in MRI machines or better training
Yeah.
instead
And
of giving.
and you see that in other areas where the number of federal employees has increased over time.
Yeah.
For any significant changes in delivery for society, I'm not sure. But again, it's that same scenario, right? Why is that trend happening across different industries?
Yeah. Why is people working in their underwear with a dress shirt or a blouse on at their home for 4 days a week?
Mm-hmm.
And I had a friend that worked in, kind of a side note, but I had a friend that worked in the federal government, and he no longer is there. But when he was there, he would say, like, man, I do like 20 hours worth of work
Mm-hmm.
a week.
Mm-hmm.
And when he told his boss that he was able to get it done in 20 hours, can I get more work? His boss was like, no, no, like keep that DL, like keep that,
Right.
right? But it's that same process where bureaucracy and money taints things.
Hmm. Hmm.
And you're paying people to do work you don't need to because it's tax funded versus if you were an entrepreneur and you owned owned a hospital and it was your own hospital, you wouldn't be able to survive by running in the negative.
Correct.
Yet every hospital, not every, holistically across the board in Canada, you can look it up. Their last year was under 100 billion.
Hmm.
So they spent 2025. They spent 142 billion dollars on healthcare. Last year was 400 billion.
Mm-hmm.
So the amount per patient has doubled. Admin has skyrocketed. Healthcare services across the board are getting worse for wait times.
Hmm.
I'm not. Yeah, there's just a lot that's alarming.
If if that was in the corporate world, there'd be a transformation.
Yeah, your
Right.
business would close.
Yeah.
You would be
Or a drastic transformation needs to be done.
call to arms meeting. We got to fix this right now. Like,
Yeah.
let's change all these processes.
Again, you have to go back to why healthcare system? Like, what's the why?
Yeah.
Right.
So then, if you go from that place, it's like if the answer is improving people's health, why do we feed them Wonder Bread?
So then from the why, then you can extrapolate how we're going to do this and what, right? I think Simon Sinek, he's a motivational speaker. You probably heard of him.
Yeah.
Like he talks about companies that understand their why, right?
Mm-hmm.
And they align everything to that.
So how do we get a hospital? Well, just North Bay that you guys work in. How would you and other doctors get the hospital to change the food that's given?
You know, our hospital's been very good with respect to change management. Like we've implemented a lot of things that are evidence based and help with patient care. So I think if we raise it, I think our hospital's open to suggestions and changes, right? So all we'd have to do is ask, to discuss this.
And then what would you recommend patients do to see more change in terms of the food in hospitals?
Hospitals, rely on patient feedback and experience, right, to improve things. So I think every patient, the thing is, patients don't understand this is not real food because most patients will eat this stuff at home.
Right.
So it's not, for most patients, not any different.
For some
But
people, that food is even better for them than what they're eating at home
exactly.
in some cases.
So really, it comes down to what's nutritious for the patient, right? Um, and that's what you have to sort of ask.
Got it.
So in order to change that, then there has to be sort of, again, stakeholders for that change to happen.
Right.
And stakeholders would include the patients, right? And patients' feedback about the food and actually analysis of what patients are getting in terms of nutritional value, right?
Mm. And then two more things. If you knew the end result being right now, because the future hasn't happened yet, if you could go back in time to when you were 20,
Mm-hmm.
what's the number one thing that you would have changed about yourself then?
About myself,
Yeah.
being healthier,
Mm.
like understanding that more, because our culture is about food. It revolves around food as well, right? A lot of cultures revolve around food. But understanding how to eat, when to eat, how to actually work out, and be fit. Um, I think that's one thing I would probably change.
Interesting.
I was active. I played sports, but I was overweight. Couldn't run like 2 kilometers, right? But I was a sprinter, so I could do bursts of sprints. That's why I could play hockey, floor hockey, could play basketball, because there's not this continuous endurance of energy that's needed and hard health that's needed, right?
Mm-hmm.
So that's what I would change. I think my fitness level and eating habits at that time.
And the last one would be if you never worked another day
Hmm.
in healthcare or
Okay.
as a doctor
Yeah.
or in any capacity, Would you be complete with what you've done in your career?
Mm-hmm.
Why is that?
I take every experience as fulfilling. Like it's not an accumulation of things, but each patient interaction I have is fulfilling, right? If I just treated one patient and made them better, that'd be fulfilling
Hmm.
because that's my goal, my approach to patients, right? If I made one patient feel good, then you've done something.
Right. I like that.
It's not this accumulation of, oh, I've treated this many patients, but did you actually have an impact on them? Each and every one of them, right? So even if I had a positive impact on one patient, that's fulfilling enough. Everything else is like a bonus.
Well, that's a great way to end this because you've had a great impact on me.
Mm.
And I really appreciate you taking this. I went long. This is probably 3 4 hour podcast. Uh, yeah, I know your time is very valuable, and taking this time is really great.
Yeah, it's awesome.
Hopefully, it motivates more and more people in your field to keep being more public with information and striving for change.
I think in the end, people need to realize one, what's their journey in life? Like, what do they want out of their life? And how does their health play into that role? And if there's change they can make that can impact their health, then you just got to take the first step and keep going with it because that's what's going to get you results. Like anything else, uh, there's a saying: one bad meal is not going to make you unhealthy, and one good meal is not going to make you healthy. So it's all about consistency, whether you're eating right, exercising, practicing an instrument to perform better. Um, I think it's just self-reflection and what you actually want to get out of life.
Well, that's a great share. Thank you for your time.
Yeah, it was awesome.
We'll maybe do this again one day, but for now, we'll leave it at a very, very good conversation.
Sounds good.
Thank you. We'll clap real quick. 3, 2, 1.